Sorry. Yes, you want to? Yes, please. Is there one off the door? Is that you too? Yes. Think that. Should we commence?
I think people are still coming through, the main gate, the main entrance. They're
Yes.
queuing. They're probably queuing there.
Okay, so 5 minutes.
Yeah, I'll
5 minutes.
should give them 5 more minutes.
So should I announce that now?
I mean, it's getting gradually full, but
Yeah.
let's
Just wait for
let's
it to
wait
be
5 more minutes.
5 minutes and then start just commencing. Yeah.
Let me go outside and I'll give some people in. Just one question. When it gets to go up, if you want, I can just sit down.
Good afternoon, everybody. We will commence the forum within 5 minutes, so please be seated.
So good afternoon. It's not 5 minutes yet, but I will. I might as well start. Distinguished guests, colleagues, and friends, welcome to the 2026 Dr. Lee Jong-wook Memorial Prize for Public Health Forum. Under the theme, Dr. Lee Jong-wook's Legacy and Future of Global Health Leadership. So today we gather to honor the life and enduring vision of one of global health's most transformative leaders, and to reflect on the road ahead. We sincerely thank all our speakers, panelists, and participants for joining us today. To begin, please join us for a short tribute video celebrating the legacy of Dr. Lee Jong-wook and the spirit of Memorial Prize for Public Health. Thank you. So it is now my great pleasure to invite to our first speaker of opening remarks. Mr. Robert Mardini has long championed humanitarian and global health efforts through international leadership and public service. He currently serves as Director General of Geneva University Hospitals. Please welcome Mr. Mardini with a big round of applause.
Thank you, Madam Moderator. good to be here. President Ha, Director General Lavater from the International Hospital Federation, Excellencies, ladies and gentlemen, dear colleagues, dear partners, dear friends of global health. It is a great honor and privilege for me today to open this ceremony of the Dr. Lee Jong-wook Memorial Prize for Public Health, here in Geneva on the occasion of the World Health Assembly. We gather today in a place and at a moment that truly matter. Geneva, we all know it, is a special ecosystem, and there is certainly no better place than the campus biotech to exemplify the richness of this ecosystem. It is a unique crossroads where knowledge, commitment, collaboration, multilateralism, and responsibility converge in the service of global health. At the heart of this dynamic is the Geneva Health Forum, which we co-founded together with the University of Geneva and which proudly celebrates this year its 20th anniversary. Since 2006, the GHF has become a living, inclusive, and neutral platform bringing together stakeholders from across sectors, policymakers, academics, healthcare professionals, civil society, and the private sector to exchange ideas, challenge perspectives, challenge sometimes the status quo, which is always a good thing, and above all, to build concrete solutions to global health challenges. And in an increasingly fragmented, polarized, and tense world that sees multiple geopolitical shifts, unfortunately, this ability to connect, to build bridges, to bridge divides is not just invaluable, it is absolutely critical. It is a clear condition for progress. The ceremony that brings us together today embodies this very spirit. The Dr. Lee Jong-wook Memorial Prize, established in 2008, recognizes outstanding contributions to public health, particularly those that serve the most vulnerable populations. It bears the name of a leader whose vision, and we've seen it, remains deeply relevant today. A vision, a very simple vision, a vision of health for all, without distinction, without exclusion, without discrimination. Dr. Lee Jong-wook embodied a form of leadership grounded in equity, access to care, and collective responsibility. His legacy continues to inspire us and also to challenge us. I would also like to warmly acknowledge the commitment of the Korea Foundation for International Healthcare, the KOFI, which sponsored and sustains this prize. Through its work, KOFI actively strengthens health systems, supports medical education, and promotes sustainable international partnerships. It reflects a powerful conviction that global solidarity and cooperation are indispensable to reducing health inequalities around the world. The laureate we honor today, Professor Mohammad Abdul Faiz, perfectly illustrates this commitment. His work on snake bites envenoming reminds us of a reality that is too often invisible, the burden of neglected tropical diseases that affect millions of people, particularly in the most vulnerable regions of our planet. For many years, underestimated snakebite envenoming was recognized in 2017 by the World Health Organization as a high-priority neglected tropical disease. This recognition did not happen by chance. It is the result of years of research, advocacy, and field engagement to which the Geneva University Hospitals and the University of Geneva have actively contributed through long-standing projects in Africa and in Asia. This reminds us of something fundamental. Progress in global health happens only when science, field experience, and institutions work in collaboration, work hand in hand. This approach is central to our mission. At Geneva University Hospitals, we are deeply engaged in this collective effort in close collaboration with WHO, notably through our WHO collaborating centers. We have 6 of them, and we cherish them, and they contribute in very concrete terms to global health and to the collective effort. They contribute to international standards, to guidance, and to sharing and spreading expertise across geographies and hierarchies and across borders. But beyond structures and institutions, it is above all a set of shared values that unites us: scientific excellence, ethical commitment, and a deep determination to serve those who need care the most. Today, the challenges we face are immense. Inequalities persist, crises, health, climate, humanitarian are multiplying and are deepening. Health systems are under extreme strain and pressure, and yet, there is also reason for hope. Never before have we had such knowledge, such innovation, and such capacity and potential for collaboration. Never before have the connections between global decision-making and field realities been so critical. This is precisely where the Geneva Health Forum plays a vital role, by bridging the gap between global policy discussions and real-world health challenges, helping to turn dialogue into concrete action. The prize we present today is a powerful message, a message to each of us that individual commitment can have global impact, that perseverance in science can shift international priorities and shape the global health debate, and that the health of the most vulnerable must remain at the center of our analysis and at the center of our decision-making. Allow me to conclude with a wish. May this moment be not only a celebration, but also a source of inspiration. May the journeys we honor today encourage us all to go further, to innovate, to collaborate, and to be bold. And above all, to never lose sight of what unites us, the profound conviction that health is a common good, health is a public good, and a fundamental human right. Thank you very much for your attention, for your commitment, and I wish you all an excellent ceremony.
Thank you, Dr. Mardini, for your insightful remarks. Next, please welcome the President of Korea Foundation for International Healthcare, Dr. Ha Il-soo. As a medical doctor and educator for over 40 years himself, and now leading Korean government organization specializing in healthcare official development assistance, President Ha has played a pivotal role in strengthening Korea's global health cooperation and partnership initiatives. Please welcome Dr. Ha with a warm round of applause.
Thank you, Dr. Robert Mardini, for your warm welcome remarks. Good afternoon, distinguished guests, ladies and gentlemen. Since last year, the Korea Foundation for International Healthcare has invited the recipient of the Jong-wook Memorial Prize for Public Health to Geneva Health Forum to share the achievement and experiences of the laureate while discussing the future of global health with the panelists. As we mark the 20th anniversary of Dr. Lee Jong-wook's passing this year, we honor his lifelong dedication to achieving health for all and remain deeply committed to carrying forward his noble legacy. Reflecting his vision, the theme for this year's forum is the legacy of Dr. Lee Jong-wook and the future global health leadership. Through this theme, we aim to honor his philosophy and spirit while collectively discussing the future direction of global health. We are honored to hear directly from Professor Mohammad Abul Faiz about his remarkable journey in strengthening the national healthcare system and promoting evidence-based medical practice, as well as his reflections and insights gained through his long journey. In addition, today's forum offers insightful, engaging sessions exploring the global health leadership and commitment, along with the crucial roles of public intelligence and the younger generation in shaping the future of global health. I am confident that through these lectures and discussions, all of you will exchange wisdom and insights to break through the various barriers in global health we are facing. Once again, I would like to extend my heartfelt congratulations and deepest gratitude to Dr. Faiz. I also express my sincere thanks to Dr. Jiho Cha, Dr. Jerome Kim, and all distinguished speakers and panelists, guests, and organizers of this forum. Thank you very much.
Thank you, President Ha, for the warm remarks. Next, we will now hear congratulatory remarks from the Minister of Health and Welfare of the Republic of Korea, Dr. Eun-kyung Jung. She will deliver her message in video.
Good afternoon. I'm Jong Eun-kyung, Minister of Health and Welfare of the Republic of Korea. It's a great honor to celebrate the opening of Dr. Lee Jong-wook Memorial Prize for Public Health Public Forum. I would like to express my sincere gratitude to Mr. Robert Maldini, the Director General of the University Hospital of Geneva, and your excellencies and colleagues from WHO and COPI for organizing this forum to discuss Dr. Lee's legacy and the future of global health leadership. The Korean government and WHO jointly established this prize to honor Dr. Lee Jong-wook, the late 6th WHO Director General. It commemorates his lifelong commitment to combating global disease and promoting the health of humanity. Professor Mohammad Abul Faiz of Bangladesh, who is this year's 18th laureate, has made substantial contributions to infectious disease response and clinical medicine, particularly in toxicology, AMR, and the improvement of healthcare systems. I offer my sincere congratulations to you, Professor Faiz. The year 2026 marks the 20th anniversary of Dr. Lee Jong-wook's passing. With a vision of health for all, he dedicated his life to eradicating global infectious disease and improving health equity. His devotion and leadership continues to serve as a vital beacon in global health cooperation today. It's a precious legacy that we must carry forward. In this regard, the theme of this year's forum, Dr. Lee Jong-wook's legacy and the future of global health leadership, is more meaningful because it clearly presents a direction that we have to take going forward. Upholding the legacy of Dr. Lee Jong-wook, we are faithfully fulfilling its role and responsibility within the international community as a global pivotal state. The Republic of Korea proudly operates the Dr. Lee Jong-wook Fellowship Program, a training program that invites healthcare workers from low and middle-income countries. With this program, we support a lot of healthcare professionals in bolstering their capacity. Furthermore, through healthcare ODA programs, we are realizing the value of co-prosperity. We have partnerships with low and middle-income countries in areas like infectious disease response, maternal and child health, and healthcare system development. The Republic of Korea will continue to deepen its cooperation with the international organizations, including the WHO and countries around the world. We are honored to be joined with distinguished experts from academia, industry, and government here. I believe this forum will serve as a valuable platform to share innovative visions and strategies for strengthening global health leadership and paving the way toward a healthier future of all. Thank you.
Thank you, Dr. Jong. We will now hear congratulatory remarks from Dr. Saya Piukala. Dr. Saya is a renowned public health leader and the WHO Regional Director for the Western Pacific, who previously served as the Minister for Health in Tonga. Please welcome Dr. Saya with a warm round of applause.
Excellencies, distinguished guests, colleagues, ladies and gentlemen, good afternoon. It has been a long week for the World Health Assembly and what is happening here in Geneva. And the battery is getting low, but because of the legacy that we are here today, gives us the energy to keep moving. It's great to see my good friend here, Chi-ho-ja, from the Republic of Korea. But for me personally, it is a great honor to join you today for Dr. J.W. Lee Memorial Prize for Public Health 2026. And I sincerely thank the Korea Foundation for International Healthcare, the government of the Republic of Korea, Geneva University Hospitals, and all partners for bringing us together this afternoon. This year is especially meaningful as we mark the 20th anniversary of Dr. Lee's passing. It is a moment not only to remember an extraordinary global health leader, but to reflect on how his spirit continues to guide us. And if I may, I would like to share a personal reflection. I had the privilege to attend the opening of the J.W. Lee Strategic Situation Room on Wednesday evening at WHO headquarters. You know, standing there, hearing the reflections shared, and especially the beautiful words from Dr. Lee's wife, I was deeply moved. In that moment, I felt as if I knew him. Not because I met him or worked closely with him, but because I could feel the heart between his leadership. You know, a heart guided by one purpose: to serve people, especially those most in need. And that is the legacy of Dr. J.W. Lee. He believed in equity. He believed in solidarity and the fundamental right to health for all. He showed us that global health leadership is not only about technical excellence, it is about compassion, it is about courage, and it is about commitment to equity. His work, expanding access to essential medicines, strengthening preparedness, advancing universal health coverage, and investing in health workers and communities, continues to shape WHO priorities today. And his legacy feels even more relevant in the world we face now. We are living in a time of growing complexity, climate change, emerging infectious diseases, aging population, misinformation, and widening inequities in access to health services and financing. These challenges remind us that health development and resilience are inseparable. In my region, the Western Pacific region, is home to more than 2.2 billion population. We see this reality every day. Pacific Island countries face rising seas, extreme weather, food and water insecurity, and climate-sensitive diseases, while many others are managing aging populations and increasing non-communicable diseases. And these realities remind us of one simple truth: no country and no institution can face these challenges alone. This is why partnership, trust, and solidarity matter more than ever. And today's forum is timely. It asks how we move from reflection to action, how we strengthen One Health, how we mobilize financing, and how we empower the next generation. And I am especially encouraged to see young leaders here today. Young people are not only the leaders of tomorrow, they are shaping solutions today. And we must ensure their voices are heard and their leadership supported. I also want to recognize the Republic of Korea's growing leadership in global health. Korea's journey from aid recipient to global partner is a powerful example of resilience and solidarity. And today, I want to congratulate the 2026 recipient of Dr. Lee Memorial Prize for Public Health, Professor Mohammed Abdul Fayez, whose career has focused on public health impact for underserved population and capacity building, exactly the spirit of service we are honoring today. Dear colleagues and dear friends, the greatest way we can honor Dr. Lee is not only by remembering him, but by continuing his work, by building stronger, more equitable and more resilient health systems, and by ensuring that no one is left behind. And by holding on to that same spirit of service that defined his life. And as we say in the Pacific, piki piki hama, kai vai vai manawa. Bind the canoes together and share breath as one. Let us move forward together with one purpose, as one region, and as one global community. I wish you all the best and a successful forum. Thank you.
Thank you, Dr. Saya, for the impressive remarks. Before we begin our keynote address, we will take a brief group photo with our distinguished speakers and guests. I would like to invite all the people sitting in the first two rows to come up front to the stage. Thank you. Please take your seats. We will now begin our keynote address. We are honored to begin today's program with a keynote address by Dr. Jio Cha, member of the National Health Assembly of Republic of Korea. Dr. Cha is a physician himself and global health scholar and humanitarian practitioner with 2 decades of frontline experiences in complex emergencies. Now a member of the National Assembly of the Republic of Korea, he leads the Global AI Hub initiative, linking 9 UN agencies and 3 multilateral development banks, carrying forward Dr. Lee Jong-wook's legacy with a vision for global health architecture grounded on equity, solidarity, and public intelligence. Please welcome Dr. Cha with a warm round of applause.
Thank you so much today for allowing me to join and have a chance to keynote here. Because I also have a lot of things to share with you, and especially related to the Dr. Jong-wook's legacy. And when I started my career around 2004 and 5 as a humanitarian physician at the time, so his last 3 years totally overlapped with my first 3 years as a humanitarian physician. At that time, I first working at the North Korea refugee centers, and so treating North Korean refugees who just arrived in South Korea from their journey from the Great Famine in mid of the 1990s, and also early 2000. There are lots of the human trafficking across the border, and then those group secondary moved to the South Korea, and I was there as a physician, very young physician, without any knowledge on the North Korea at that time. But when I see my patient, I could realize, and their pathology is not rooted in their biological body. Their symptoms, disease are all deeply rooted in their political structure, which make a failure of the series of the social system failures. And also, on the other hand, they some kind of create purpose to make them displaced from their country, and then be very vulnerable into the human trafficking process and etc. So if I were the doctor or physician who see the cardiovascular disease, and that is like I looking at some underlying pathology of the heart, but as a physician who see the refugee, their body, and my idea is a bit more deep diving to the underlying political pathologies of all of the human being and our health are deeply rooted in. So since that, my first journey is that how to address political determinants of health and health system and health crisis. So on the one hand, I have worked with MSF, Doctors Without Border, in the North Korea border area, and to provide direct medical consultation and develop some informal, some healthcare network, and because most of our work would not be official at that time. And also in North Korea, there is no formal route to enter, and so throughout the refugees and those groups, and we try to find a way to support left behind their family inside the North Korea border. So all of those work is not a typical humanitarian practice, but at least it was a very great opportunity to see what is the reality of the global health, what is the reality of the human being in this complex atmosphere. So my journey have continued with the Human Rights Watch or the other human rights organization, and moved to some more health system research and practice, especially in the context of the humanitarian crisis and etc. So what I found is that our world is purely divided by politically and also socially, economically. And then in the middle of the 21st century, all of you are here who are engaged in the global health issue. Even though on top of our more than 20 years effort, world is still suffering, and many children could not access the proper diagnosis and etc. Elderly group they suffer a lot without proper diagnosis and treatment package, and then also sustainable health system. So maybe those kind of political determinants already reflect into the crisis of the WHO and crisis of the current global health architecture, because all of those global health architecture are also deeply rooted in the contemporary world order, and which allow the extreme inequality and extreme divide. And we see that we naturally accept it is our world. But if we have a chance to change, like Dr. Jong-wook said, and his famous word for me is that to the right things and right away. So we need to figure it out what is the right thing at the moment and to change our world. And his colleagues and provide us another courage to make some change. So if world is stable and world does not under the crisis, and I believe we can make some minor revision of our healthcare system or minor revision of our food or the other humanitarian system. But problem, maybe opportunity and crisis, the characteristic is the world is under great transformation, especially with the climate change and also the other global health threat and conflict and the changing instability of the economic system and etc. All of those kind of crises now packaged as a public crisis. So maybe we can consider first on the climate change. All of you knows climate change, its impact, but maybe not many the climate crisis, even experts, they don't know exactly what kind of the complex pathway from the climate change to health and the increased mortality of the people, etc. So in that case, we need to address the cascading impact of the climate change. Climate change, there is not a single pathway to impact on health, but maybe when the key context I work in the lots of documented crisis, there was already climate change impact, especially on the people's change in mobility, and also that change in mobility increased social instability, and changing social instability can increase the risk of the conflict, and then if armed conflicts happen, everything is collapsed again. So those kind of virtuous cycle is now compounded with the other crisis event and like changing political economy, and which increased a lot of the risk of the conflict and changing pattern of the conflict, what is happening in the Ukraine, Gaza, and Iran and the other contexts. And a lot of the global leaderships and who are the mitigating or to scale back from their role on to stabilize world, and maybe they are now acting a bit differently compared to the last century. So in that case, we need to revisit again on our role as a global health actor. We accept this global structure, and then we only treat the symptomatic result from this disorder of the world structure, or we may need to engage a bit actively on to change the fundamental structure of the global order. So for me, and if Dr. Jong-wook still here in this stage, and he may say we need to change the fundamental structure of the health crisis, fundamental structure which make half of our global population make them vulnerable, and those kind of things. So world is still divided again, and politically, economically, and socially. But I found there is another driver which are transforming world, and I found it digital and artificial intelligence. And because the current world order is emerged and stabilized after industrial revolution, and now we are encountering new industrial revolution with the artificial intelligence, and then it may provide a lot of the significant driver to changing our industry and changing our labor structure and changing international security matter. I can make a very specific example on that, but fundamentally, what I would like to address is that one of the key fundamental determinants of the global crisis and also health inequality, what I found is that the intelligence determinants of health. And because before the artificial intelligence, all world system is deeply rooted in the human-only intelligence system. And you know, the human-only intelligence system, there is huge imbalance and inequality, and if we make a better human health professional and or lawyers or scientists and etc., we need at least more than 20 years stable education system. But in many corners of our world, it is rarely possible. Even though there are external ODA or economic kind of contribution from the other sector, without the human intelligence system, mature human intelligence system, it cannot be translated into the more stabilized social system. So it was one of the key bottleneck at the moment. But about 10 years ago, and when AI emerged again as a promising technologies, I quickly accepted it as a game changer because at least artificial intelligence make some change on the pattern of the intelligence system in this globe, and which the most context I work is that another corner of the very unstable and also very weak the human intelligence system. So maybe we can, if we can add up this intelligence new layer of the intelligence system on top of the unequal human-only intelligence system, maybe we may have another opportunity. Because in this speed of the development of AI, maybe it is much faster to make maybe 10 million doctors, and it takes another 15 years. But in this speed of artificial intelligence, we can see the more artificial intelligence we can combine with the existing health professional to scale up the level of the clinical capability in the level of the medical doctor. So artificial intelligence can be used to aggravating current security structure with the adapted as a warfare, and also aggravating current inequality of the economic difference and etc. But it can also use to mitigating that kind of severe inequality and mitigating the negative consequences of the current, the unequal human intelligence system. So South Korea, this is not only the vision, and we are very actively implementing or translating artificial intelligence into the existing social system. So this, the framework, we call it the AI Universal Basic Society, using AI as a public intelligence. And it's kind of the intelligence infrastructure so that all of the citizens or small enterprise or small scale clinic and those kind of group can access this new intelligence layer without barriers. I think we should consider AI as a public intelligence and intelligence infrastructure so that based on that, the industrial competition or competition between the country can be emerging. That is okay. But if we fail to use artificial intelligence as a form of the public intelligence, maybe it will resemble current inequality between the countries and between the global north and south and between the individual, and then it will aggravate again on the current unequal structure. So recently, this AI Universal Basic Society, this idea is shared with some of the UN agencies, and including the UNDP and WFP and also ITU and IOM and UNHCR. So just yesterday we have the declaration event with the DGs of this particular UN agency. 9 UN agencies are now gathered to have building a consensus on the global AI hub, and which try to make artificial intelligence for the more people-centered the healthcare system, people-centered social protection system, and people-centered migration governance, and etc. That is happened yesterday in support of the 5 different multilateral banks. So I think currently our world is still combined with the traditional, the very unequal industrial system or economic system, which are strongly linked to our order of the capitalism. But maybe we may encounter very new, very novel opportunity in next 5 years. Because many futurists or AI experts, they see the AI revolution, first cycle of the AI revolution will be done in next 10 to 15 years. And it means next AI society, the architecture of the next AI society globally should be designed in next 5 years. So if we are living in the very stable world, and if we will not encounter cascading impact of the crime crisis and or another public crisis event, maybe we can keep this system with some minor revision. But I would like to tell you, based on my last 2 decades humanitarian work in the global crisis context, we don't have such a system. We don't have a global crisis resilience system which make our people protected from under this emerging great risk of the global crisis. And UN agency, we are weaker than people. And we are under triple crisis: political leadership crisis, financial crisis, and also technological crisis. I'm not sure UN have currently enough technical capacity to encounter this crisis. UN does not have enough financial resource to encounter this level of crisis. Then, like a context, humanitarian crisis context, I have worked for in the last 20 years. Maybe we will witness the tons of the deaths and the social suffering from this very unstable transition. So, what I wanted to talk you at telling you is that like Dr. Jong-wook's word, we should do right things right now. Without those kind of quick and massive movement at the moment, and maybe we may lose the golden time and to make transforming our world in the better kind of status and more resilient. And in that case, is the current great transformation of artificial intelligence into each societal level, it is led by the private sector. Some of the private sector and big tech company, they internally doing very well with some monitoring system, and then lots of engineers try to make their technology for the better world. But they are outside of the public governance. And if artificial intelligence or another layer of the grand transformer work in the negatively or work in this structure of the inequality, I don't think we may have a better world compared to the period of the Dr. Jong-wook. So I would like to address again, bridging the past of the Dr. Jong-wook's his effort, and also preaching there are some of the new generation and new future leaders. I can see your effort and your perspective on the contemporary world. Maybe we can redesign the global architecture, and which are deeply rooted in these great transformers as AI or climate and etc. So I hope all of us or all of you, we can make our effort together for the better change. Thank you so much.
Thank you, Dr. Cha, for the thought-provoking address. We will now begin session 1, the highlight of today's forum, the Laureate lecture and panel discussions. This special session honors this year's Laureate of the Dr. Lee Jong Memorial Prize for Public Health and reflects Dr. Lee's enduring vision of global solidarity and health for all. Today's discussion will explore how One Health approaches can strengthen preparedness, resilience, and international cooperation in addressing emerging global health challenges. Chairing this session is Professor Rafael Ruiz de Castaneda, a researcher and educator at the University of Geneva, specializing in One Health, zoonotic diseases, and global health collaboration. Please welcome our chair, Professor Castaneda.
Thank you very much. Good afternoon, dear colleagues, distinguished guests, experts, and dear friends. And a warm welcome to this very exciting session on One Health, climate change, health system strengthening. The specific topic and the specific title of this session, one, that we are covering now, is From Talk to Action, One Health in the Real World. My name is Rafael Ruiz de Castaneda. I am based here in Geneva at the Faculty of Medicine, and I lead the One Health unit at the Institute of Global Health, just the building just behind us here. And I'm really pleased to share this session. I was really happy when I got this opportunity. I'm just back from the field. I spent the last 10 days working in Kakuma refugee camp. This is a huge refugee camp, one of the biggest refugee camps in sub-Saharan Africa, sitting in the northern part of Kenya, just across the South Sudanese border. Just to give you an idea, this camp hosts and brings together more than 200,000 people, mainly refugees from Sudan and South Sudan. It's bigger than Geneva, right? And they live in extreme environmental conditions, highly vulnerable population, highly climate vulnerable population. They live simultaneously with malaria, rabies, snakebite envenoming, leishmaniasis, mental health, heat stress, among other climate-sensitive diseases. So I think session one today, together with amazing experts and colleagues and collaborators that will be sitting here in the panel and the presentation, will have the opportunity to actually think together about how we can take One Health from talk to action, how we can take One Health all the way from Geneva to refugee camps, to humanitarian settings, to rural environments, and other settings where people are suffering the impact of climate change particularly hard. So the session will be divided basically in two parts. We'll have a first part with a presentation by Professor Faiz, and then it will be followed by a discussion with distinguished experts and global health leaders. With no further ado, I'd like to invite Professor Faiz to join me on stage. Professor Faiz, I've been following his work for years. I also work on snakebite envenoming, and he's been such a source of inspiration for all this year. He's a physician, he's a public health leader, he's done amazing work in the field of malaria, snakebite envenoming, and other entities and climate vulnerable diseases in Bangladesh, but more broadly also contributing very actively to the work in the CRO WHO region. Professor Faiz, thank you so much for joining us, and congratulations one more time for this prize. Thank you.
Thank you. Thank you very much. Honorable Chair, Excellencies, distinguished panelists, experts, and very distinguished audience, good afternoon. I feel very honored and privileged to speak in this important Geneva Health Forum on the very auspicious occasion of 20th anniversary of demise of passing of Dr. Lee Jong-wook, and also on the celebration of award ceremony. I'm speaking in front of such a group of audience who are very committed, and also speaking on the part of a group of healthcare professionals with whom I worked for a long period. Over the next few minutes, I shall try to highlight some of the activities that we are collectively doing in the resource-limited settings of Bangladesh. Being a faculty in a resource-limited situations, we had three group of responsibilities. Development of the human resources, providing conventional lecture, providing clinical teaching in the bedside, and doing some bedside laboratory procedures, leaving really very little time to do research due to the very real life scenario. I'm sorry, some of them are not very comfortable. There are resource limitation in every aspect in terms of human resources, logistics, diagnostics, whatnot. For example, in a single day, in an adult medicine unit having capacity of 66, there are 237 patients with 115 admissions in previous 24 hours. 10% of them require critical care. And if you visit such a ward in a single day, these wide range of conditions are there, and including some of the conditions which are not appropriately taught in the medical curriculum, nor there is harmony amongst the professionals to address. And particularly, the less priority area is institutional research on those topics. So some of the examples are here. When we are investigating an outbreak of suspicious febrile encephalopathy with possible avian influenza, we found that this is nothing to do with the infections. Rather, in a drought area, an outbreak happened due to the Xanthium strumarium poisoning due to plant ingestion. Some of the examples of field visits are being reflected here. With the support of the government in our region and the World Health Organization, our countries were aspiring to eliminate one of the deadly diseases of our region, the leishmaniasis Kala-Azar, in 2005, and the program started in 2008 after planning, and within a short period, the target of achievement of elimination of Kala-Azar as a public health problem was achieved and certified by the World Health Organization. And so at the point of 2008, when there were 8,000 cases have been reported, currently in 2024, less than 50 cases have been reported, with half of them are post-Kala-Azar dermal leishmaniasis, rest half are recurrent Kala-Azar. So primary Kala-Azar is less than 25, putting them into a difficult situation of treating them. Although earlier we used to use them 28 days sevogluconate. Diagnosis was by splenic puncture or bone marrow, but subsequently rapid diagnostic test and single dose liposomal lymphocytes can be preceded by earlier 28 days oral miltefosine, change the whole situation. In the other area, the pesticide poisoning by organophosphate, the only drug was atropine plus minus pralidoxime 50 years before. There is no additional drug developed. So we try to repurpose the other drug like magnesium sulfate or nimodipine as a calcium channel blocker in 8 hospitals across the country and across the country on those areas, with the primary endpoint of to see the mortality, with secondary other endpoints like atropinization, etc. Within a few years during COVID period, with a target of more than 3,000 subjects, we could recruit 1,800 subjects with more than 500 cases in each arm. And in this case, we could not detect any significant difference. The DSMB asked us to stop the trial due to feasibility trial. So in terms of mortality, and the patients requiring intubation, time to atropinizations are not different. Coming to the topic of snake bite, amongst the neglected tropical diseases, even in the countries, Out of 21 neglected tropical diseases, only non-communicable disease is snake bite. So it does not fit either in the communicable diseases where that deal NTD, nor the non-communicable diseases who are overburdened with classical non-communicable diseases, hypertension, diabetes, stroke, coronary artery disease, etc. So in the situations like 30 years before, there were no ventilators or the critical care was not there, but despite the oral technology of 1953 during polio era, we could change the situation as been seen in the picture below. Diagnosis was not evidence-based because there was no classical diagnostic test. One example is 10% patients being dead or alive specimen. This is a treasure that can be utilized. Those are fortunate survivors. They develop lots of disabilities. Some of the examples are here. We are very grateful to our collaborators, Professor Sir David Worrell, Professor Don Harris and others who participated in those areas, providing enormous opportunity of generating evidence based in resource-limited situations. Even discovery of the new species of crate, black crate. There are 5 varieties of crate. This is the only crate that can cause not only neurotoxicity, as has been shown in the figure, followed by very dark color, Coca-Cola-like urine, as if there is black water fever. Really, this is a skeletal muscle damage caused by the same species, and this is a unique example of the discovery of the black crate causing paralysis, kidney injury, and huge fatality. The World Health Organization was very eager to work on snakebite since its inception, providing a very important global report in 1953. Shorup and Greb reported that 50,000 cases used to die in 1953. There was no disease like snakebite. This is buried in the injury until recently, as has been mentioned by our colleagues, by Honorable Chairman, that the snakebite strategy was formulated, management guidelines developed, the various regional and country-specific strategies developed, including Bangladesh. We could develop this country strategy recently. Strategy will not work. There are various components like the World Health Organization. One of the important components is empowering and engaging communities, which fits with the philosophy of Dr. Lee Jong-wook, empowering and engaging the communities. While we were trying to engage the communities, we developed various types of IEC materials. Our community are not health literate, not to speak of AI literacy there. I wish that in future when there is equity will happen, then possibly the health literacy might be improved, but till then we have to rely on conventional methods. So we try to develop, this is the English version, the local traditional version, how to provide appropriate first aid, very old illness, but providing very old type of first aid. Not many of them are inappropriate. So how to provide appropriate first aid, what not to do, and how to avoid snakebite. These are combination together. These might work as a vaccine, as a prevention. And one of the example is here, providing the health education through traditional courtier meeting. In the small area of sub-district of having 180,000 population, we did a cluster randomized trial. We demonstrated that the simple preventive measures by various conventional and modern methods of using IEC, a group of activities has been designed, implemented by the community for the community themselves. We arranged 450 such courtier meeting in one sub-district over a period of few months, followed them one year, having baseline at the end of 1 year, 20 months, and we could detect that the preventive measures, the first aid methods, the practice of access to care has been improved mass in comparison to the control area below. It has been accepted by the PLOS neglected disease, and just last week we cleared the proof. Coming to the malaria, the World Health Organization was trying to eradicate malaria in mid-60s. During my studentship between 72 to 78, I have not seen any case of malaria in my medical school, but when I entered in the training in 1979, there were several hundred cases that admitted with febrile illness with multiple organ involvement. There was no drug, there was no diagnostics. People had forgotten the microscopy. So that initiated the first thinking, resulting in this dissertation followed by supplement on malaria in the local journal. The TDR provided some small fund for doing operational research comparing quinine versus artemether. At that time, there was no significant difference except the delayed coma recovery time, hinting either benefit or harm. Then subsequently, through the support of the Wellcome Trust, with the Mahidol Oxford Research Unit, Professor Sir Nick White, we could continue the largest trial on severe malaria, Southeast Asia quinine artemether trial, completing study within few years, recruiting nearly 1,500 subjects, 30% of them from Chittagong Medical College from where I was working. At that time, our team, they recruited 1/3 patients, and in the middle of the DSMB meeting, the study had to stop due to impressive findings of 35% reduction of mortality by using artesunate injection. The patients of severe malaria, they come from the community. The community, they don't have injectable, they do not have diagnostic, they do not have referral mechanism. So we are exploring the possibility of using alternative route other than injectable. Rectal artemisinin was in the development phase, particularly for the children. So the huge community mobilization was essential at that time. From the four walls of the medical school, we had to come to the villages, to the community, to enrich them, to empower them to participate in the study. In that study, the community awareness meeting, one of the monitors is visiting, very field monitoring in the difficult access areas, and particularly supervising them. At the end, it was found that in the children, 25% reduction of mortality is possible by providing single dose rectal artemisinin, advising them to come to the hospital, having completion of the treatment. Impressive findings by those findings, the World Health Organization, since 2015, 2025, continued the same recommendation of continuation of the injectable artesunate for management of severe malaria in hospital, rectal artesunate for the children, and the pre-referral treatment in the hospital based on these major two studies done by our group. So the reduction was possible by single dose of artemisinin. In that study, we won the BMJ award in 2010. Coming to further, with the community-based treatment followed by referral and then injectable treatment by artesunate, a significant reduction happened like Kala-Azar, like leishmaniasis. In this case, not as a public health problem, it is a true elimination. So with the nearly 100,000 cases in 2008, transforming into less than 10,000, and then in this year, by a few months before, 460 with 0 death. We are now aspiring to phased elimination of malaria from our locality, but difficult situation in the red areas. The red areas is the area inaccessible, difficult area coming to the close border with Myanmar. But there are opportunities still. The malaria vaccine has been approved by the World Health Organization, the 2 vaccines, and this can be used along with drugs. So we developed this MBDA, mass drug and vaccine. So here we started this combination vaccine and drug, with drug, standard of care. We have provided the first 3 doses and booster dose. Now we are following up those booster dose patients. So we visited these remote areas, the cluster randomized trial. Towards the end of the year, we expect to have the findings of the using vaccination as a part of elimination. How to take forward the legacy of Dr. Lee Jong-wook? We like to see the empowering and engaging communities, not only in malaria, snakebite, and other conditions, starting from non-communicable diseases, communicable diseases, unfinished agenda of maternal, child health, newborn health, by empowering the communities by general health care, specialist care, clinic-based teaching, as well as providing service, which is not very practiced in resource-limited settings, providing the routine health check, disease training to the patient, providing therapeutic exercise, providing adult vaccine. Adult vaccine is not very practiced in many resource-limited settings, very useful, providing utilization of the telemedicine service, health education, seminars, travel clinic, DP training and counseling. This group of work has been started through the Day of Care Foundation. We like to consolidate on this for the empowering the community for taking health of their own. This is a long-term work of the group of colleagues. On behalf of them, to the founders, with the Ministry of Health and Welfare, Bangladesh, we try to consolidate the very basic informations. I am very happy that the learned audience in this room are the voice of the voiceless. I like to echo with you that let us continue our work together to continue to target this remote, rural, unaddressed community in different parts of the globe. Thank you very much indeed for kind attention. Thank you.
So thank you so much, Professor Faiz, for this, for taking us through this really amazing journey at the interface of science and policy, but I would add more, science, policy, community interface, because I think your work and your career has really navigated the three fields, the field of science, medicine, policy and engagement, and community engagement, which is absolutely crucial when it comes to better understanding, preventing, and controlling these public health issues at the interface of people, animals, and the environment. It is also very interesting, we think about it, both malaria and snake bite are both about bites, right? Mosquito bites and snake bites, right? Very different diseases, but still public health issues at the interface of people, animals, and the environment, both climate-sensitive diseases, and both really very relevant for the One Health conversation that is about to start. So I'd like to move now to the panel discussion. And I'll be accompanied by a group of experts and global health leaders representing different sectors. We'll have the World Health Organization, Gavi Alliance, the Vaccine Alliance, and academia as well. So I'd like to start and invite Dr. Park. Dr. Park works with the World Health Organization in Western Pacific region. He is the director of the management program of strategic planning, budget, and health system strengthening in the Western Pacific. Dr. Park, please join us on stage. Thank you. Yes. Next, let me invite Dr. Nishtar from Gavi. Dr. Nishtar is the CEO from Gavi, the Vaccine Alliance. She is a physician by training and a global health leader with more than 30 years of global health leadership. And also, she served as the special assistant for the Prime Minister of Pakistan. Please join me on stage. Thank you so much. And finally, representing academia, at Yonsei University, we have Professor Kwang, who is also the president of the Korean Society for the Unification of Health and Medicine, former director of Korean NIH, and you were also seconded at the World Health Organization in Geneva during Dr. Lee's tenure. Thank you so much for joining us. Okay, so I'm very impressed. This is an amazing group of leaders and experts, and I'm very pleased to be part of this conversation. So let me start with Dr. Nishkar, if I may. I'd like to hear from you on how, in the context of a very rapidly, we're trying to frame this conversation a little bit around the climate crisis and One Health. So in this rapidly changing environment and the rapidly changing landscape of infectious diseases, right? How is Gavi, and more broadly, how do we improve timely access and equitable access to vaccines, particularly in areas of the world where climate change is hitting highly vulnerable populations? Thank you.
Well, thank you very much for this conversation on One Health. I think it's becoming increasingly evident that there there's an inextricable relationship between animal health, human health, and environmental health. And in our line of work, we see it playing out very, very often now. So diseases are appearing in areas where they were not recognizable at one point in time. And of course, vaccines have a very strong linkage with the climate health nexus, because there are many diseases that are climate sensitive which can be prevented by vaccines. Yellow fever is a case in point, malaria is another case in point. And increasingly we are seeing, as part of our line of work, that when climate catastrophes happen and when you get droughts and floods and torrential rains, there are outbreaks of diseases that can be preventive and tackled with vaccines as well. Over the last 2 years, we've seen an enormous increase in cholera, for instance. And of course, we then mobilize our cholera stockpiles. Yellow fever is another example. And the malaria vaccine is particularly relevant in this context. And there's a huge appetite from countries to introduce and scale up the malaria vaccine. This is the newest vaccine in our portfolio. It's taken us 30 years to get to where we are. And we have experienced the fastest rollout of any vaccine in history. 25 countries have adopted the malaria vaccine over the last 18 months or so. And there's a huge demand. So your question about equitable access is very important. And of course, ultimately, it comes down to the available funding based on the existing models. Now, I have to say that I don't want to just complain and say that funding is dwindling and funding is the only bottleneck, because there is also a silver lining. As ODA is declining, countries are stepping up and they're saying, we want to plow in domestic resources, we want to increase our resource mobilization capacity, and we are seeing that in particular in Africa. But our malaria vaccine program has taken a bad hit as a result of the program recalibration we've done, given the resource realities. As you know, Gavi is in a 5-year strategic. A 5-year strategic period has just kicked off. And our ask for this strategic period was $11.9 billion. We were able to mobilize 10. So of course, we've had to make some difficult trade-offs, and the malaria program was one of them. But while I have the floor, I also want to say that this is just the right moment to be talking about the One Health approach. And why do I say this? Because Geneva is abuzz with conversation on the global health architecture reform. They've been ongoing for the whole week. The WHO has a new process, and now that member states are going to be aligning upon. And reform of the global health architecture, and especially when it comes to the landscape in Geneva and in Western capitals, is a lot about rationalization and cutting down and reducing duplication, fragmentation, and competitive behaviors, and we completely agree and get that. But we must not forget that this is also an opportunity to build into the global health architecture the competencies that do not exist today. Dr. Cha talked about AI and the profound potential of AI. Today, there is no entity, no capability responsible for to counter AI-enabled bioterrorism threats. And the subject that we are discussing and which you steward at the university, One Health, is one of them. This is the right moment to say we need a new global health architecture which is grounded in One Health, where we are going to create the systemic incentives to break the silos between animal and human health. And it's entirely possible to do that. And I think it's not just the global health architecture, it's also about how country institutions are structured. We think governments are one entity. They're not one entity. It's an archipelago, and there are competing institutions. So now that the declining ODA has brought in a context where we need to rethink institutional structures, this is just the right moment to put One Health on the table.
Thank you very much. I think you've opened so many exciting boxes there, and I have so many follow-up questions right away. But I'd like to hear from Dr. Park, also building on what we just heard. How do you see, and based on your work in the Western Pacific, how do you see, first of all, can you maybe explain to us how do we build a climate-resilient health system, and what it takes to actually do this at the primary healthcare level and the community system level, especially considering the fact that Western Pacific, as we heard at the very beginning, is one of the areas of the world where climate change is hitting particularly strong. So can you take us through this idea of a climate-sensitive and climate resilience of the health system? Thank you.
Thank you. As mentioned by Dr. Saya Piukala, Western Pacific region is the home to 2.2 billion people. The impact of the climate change are no longer a future risk. They are already affecting lives and health system in the region every day. Climate change comes with rising temperature, extreme weather events, sea level rise, and changing rainfall patterns. We are observing increasing the spread of the vector-borne diseases, such as dengue, disrupting food systems, water security, livelihood, and mental well-being. Last year, we witnessed a sharp rise in dengue cases across the region, with several countries declaring national emergencies. Climate-related shocks are also placing increasing strain on already stretched health services, particularly in rural and remote communities. This is why climate change must be integrated into primary healthcare system. WHO advocates for primary health system resilience to climate change and climate crisis. Resilient primary healthcare systems are essential because they are the first point of the contact for communities before, during, and then after climate-related emergencies. They must be able to continue delivering essential services during disasters, detect emerging health threats early, and support vulnerable populations whose health risks are intensified by climate change. So we must invest on local health workforces and community health workers. We also must invest on disease surveillance, risk communication, climate-informed early warning systems. Not so good news is we cannot strengthen climate-resilient health system without adequate financing. Although climate finance is increasing globally, health still receives only a small portion, only a small share of the available funding. And many low-income and the middle-income countries, many climate-vulnerable countries continue to face major barriers in accessing climate and health financing. To help address gaps, WHO has launching practical initiative we call ACE-FIT, the Access to Climate Finance and Investment Tool for Health. Last year, ACE-FIT workshop engaged countries including Cambodia, Kiribati, and the Philippines. And this year, the initiative is expanding to additional Pacific Island countries. These efforts are helping countries build the technical capacities needed to develop climate-resilient primary healthcare systems. WHO in the Western Pacific region is also deepening partnership with financing and development partners, including Green Climate Fund, COICA, and then Asia Infrastructure Investment Bank to support sustainable investment pathways to climate resilient health system, climate resilient primary healthcare systems. Ultimately, strengthening climate resilience in primary healthcare is not only about protecting health systems from climate shocks, it is about protecting people, especially the most vulnerable communities who have contributed least to climate change yet face the greatest risk. This requires a strong international cooperation. By advancing this partnership and investment, we honor Dr. Lee's legacy and protect our shared future.
Thank you so much. That's indeed, both of you pointed to the funding aspect and the finances. Maybe we have time at the end. I'd like to come back to you and also explore this idea of the partnerships. Not only what are the funding mechanisms that are required, but also what are the critical partnerships that go along with that. Thank you so much. Let me now go back to this very changing landscape. As we said, we see the number of emerging infectious diseases increasing very rapidly over the last decades, right? We also see these days Ebola hitting Central Africa, Andes antivirus, both zoonotic infectious diseases. How, as an expert, Professor Kwong, as an expert in One Health and infectious diseases, what are the practical tools? How do you see One Health as a tool to facilitate international, national coordination and collaboration between sectors, institutions, disciplines?
Thank you. Before my comment for your questions, I just remember last year in Korea, Gyeongju, APEC Summit, only the Chinese leader, his name is Xi Jinping, proposed a new international organization governing AI, World AI Organization something. So, however, no other world leaders just concerned about that, do not. So I think that anyway, this area, there are so many new governance for technology even in the public flow, so we must remember. Your question, I'm surprised you remember the Hanta. Hanta is actually the name of a Korean famous river, and another Dr. Lee, Hoang Lee, found the pathogen, and anyway, I think that go ahead. Yes. I think that there are so many, several factors contributed to the emerging infectious diseases in real world. First of all, climate change, and secondly, rapid advancement of transportation and global connectivity, and the expansion of human mobility and interaction, including urbanization and the migration. So I think that Dr. Lee also emphasized the partnership, even the responding to the threat of emerging infectious diseases. So One Health is just the necessity. So we must focus on based upon One Health approach. One Health recognized the interconnectedness of human health, animal health, and the environment. It calls for integrated cross-sectoral collaboration in addressing health challenges. And One Health is not merely a conceptual framework, it must be operationalized in real-world settings. So I think that there are some three elements in One Health approach. First of all, integrated surveillance system is the basic starting point, and then secondly, collaborative response mechanisms, surely, and finally, I think that for ideal approach, joint field investigations and real-time data sharing is also very important. However, I want to emphasize, rather than any platform or technology, Dr. Lee always talk about people. So I think that ultimately systems and technologies are only as effective as the people who operate them, who operate One Health. So people is very important, and partnership is also important. So we need more collaboration and coordination between all the personal advances and the international organizations, governments, and all there are so many elements. However, we must think about that always the people. So human resources is the most important thing. to educate them with the concept of the partnerships is very important. Dr. Lee always focused and emphasized the concept of partnership based upon recognize the role of each individuals. Yeah, that's my point.
Thank you so much. One Health is by definition, this is what I always share with my students, One Health by definition is a transdisciplinary approach, and transdisciplinary means we engage with communities, right? So I'd like to move to Professor Faiz. A lot of your work, and you presented in your slides these beautiful photos, your work in the field, right, in close contact with the community. So I'd like to hear from you, after all these many years working closely in contact with the communities on malaria, on snakebite endeming, what are the challenges and, on the other hand, the opportunities or the interests of engaging actively as a scientist, as a physician, with communities that are suffering these problems like malaria or snakebite endeming? So how do we better engage with communities using One Health, in other words?
Thank you very much. I think in continuation of the comments by our learned panelists, I particularly like to refer to the climate-sensitive conditions. What is happening now? Currently, the countries being affected by climate effects, they do not have enough strong health system. At the same time, they consider this as a part of disaster. So, through the lens of disaster, through the lens of disaster means what are the casualty. So instead of considering in the terms of casualty, I think this should be a frontline priority. Health should be a frontline priority. So currently it is the trickling from the center down to the community is a long process. So also the funding process. So I think engaging the community upfront will be very essential. Engaging community beforehand during the disasters, during this impact. I think the experience currently with the various conditions, the community is quite well conversant but the process is so slow, so bureaucratic, it should be streamlined faster enough. There are good examples. For example, there is a global fund for malaria, TB, HIV. I know that there are fund restrictions, but still, this is a good example. So fund should not be discrete from different small components. Instead of that, they should be category-wise. And then at country level, this is a really multi-health, multi-ministry related condition. So this is really not only One Health, this is also one approach of whole of the government approach. So through the whole of the government approach, One Health approach is one of them. So as it requires more than one ministry, but at the end, when the community involvement related to health comes, this funding has been found to be very much fragmented, very much discrete. So community engagement with the existing knowledge, it is their problem. They can provide support, they are resilient. So I think there is no option but to engage in the community based on the existing lessons from the vaccination, from the non-communicable diseases, from the maternal health. So I think this is a common knowledge pool that can be strengthened further to engage the community for these conditions. Thank you very much.
Thank you. Thank you so much. Yes. So, Dr. Nishka, I know you have to leave us, and we are wrapping up right now. Can I ask you a final word before you leave us and before we close the session? What's your message to the audience? What's the message to the global health community sitting here today to close this session? Thank you so much.
I think we need to look at the context here, because the situation in DRC and Uganda, we're looking at an emergency, we're looking at an outbreak, and it's a very sobering moment. Because back in 2018, when the vaccine was available and at the outset there were 30 deaths and 60 reported cases, it took us 2 years to bring it under control with the vaccine available. Today, the Ebola outbreak is a very different story. We're talking about northward of 600 cases, 160 deaths. For every 2 people tested, 1 tests positive. There is no vaccine available. And I think this should be a wake-up call to us as far as the One Health is concerned. And we really need to structure the systems for these 2 streams to come together. Those of us who've worked in the health sector in countries and in global health, and I would challenge all of us, have arguably never spoken to our counterparts on the animal health side. And I think now that we are talking about global health architecture reform, we must make a proactive effort to institutionalize One Health arrangements. Unless this is done, we will never have visibility on what's happening on the other side.
Great, thank you so much. That's a very strong wake-up call, a very encouraging one, especially also for the young generation following us in the next session. Thank you so much again to all the panelists, and congratulations to all the amazing work that you're doing for global health. Thank you. Thank you very much. Thank you.
Thank you to our chair, Professor Castañeda, and to all our panelists for such a stimulating and important discussion. We will now take a short break. Please help yourself to refreshments. It's outside at the cafeteria, and then be back by 3:20. And there's an announcement I want to make. There are some hand-woven products that's made by an NGO run by Ms. Reiko Lee. And then please feel free to look at it and then get some information about the products. And then we also prepare some gifts of the products. So please stop by the desk of the products right outside of the auditorium. So please promptly back by 3:20. Thank you. So welcome back, everyone. We will now continue with session 2, focusing on global cooperation, accountability, and sustainable leadership in public health. Chairing this session is Dr. Ian Smith, Senior Advisor to the WHO Director General and Head of the Secretariat for the Global Preparedness Monitoring Board. Please welcome our Chair, Dr. Smith, with a warm round of applause.
Thank you very, very much. I should confess I am no longer the head of the Secretariat for the Global Preparedness Monitoring Board. That's been taken on by Dr. Bruce Aylward, but I was there at the launch of their last report, and I'm going to make a plug for it. Please read it. It's a really important summary of what's needed in the world today, in a period of turmoil in health, in politics, in finance, in so many different areas. It's an important report. So please do get hold of it if you can. I'm going to be chairing this session. I'm going to try and keep it a little informal. We will, of course, be shortly inviting our keynote speaker to come forward, but I'm also going to ask the other members of the panel if they could come forward now, and we'll start with everybody up on stage, if that's okay. I'll introduce them, don't worry. Give them a chance to get up, and then I'll introduce them shortly. The reason I think I'm here is because I used to work with Dr. Lee. I first met him 29th of November, the year 2000, when he was appointed as the director of Stop TB. And I worked with him then consistently until the day of his death, 20 years ago today. A great man, a man, as we will be hearing about shortly, a man of action, a real leader. And our theme for today is around leadership, and around particularly the way in which leaders can make such a difference in global health, as Dr. Lee did in his very short time as DG. There are a number of people here who, if it wasn't for him, would not be here. I count myself among them. I think there are several others, Ginny particularly, another who is here because JW was DG. Alex there as well, a number of others. I should also, I hope Wilfred is still around. Wilfred, are you? I'm afraid I can't see it. Anyway, if Wilfred is still around, he may be coming back in. Wilfred has been in WHO, or was in WHO, I should say, from 1977. Extraordinary, eh? And he worked very closely. He was a very close friend and colleague of Dr. Lee as well. I would just like to pay tribute to him too. And many other WHO staff actually in the room here now, too many to mention, who have worked with Dr. Lee or have had the privilege of seeing him at work and have followed in his footsteps in exercising in their own way leadership in global health. But first of all, it would be appropriate for me to introduce, and excuse me again, my iPad has gone off as it always does at the critical moment when I want to be reading from it. I'm going to be introducing our keynote speaker. Our keynote speaker is Dr. Jerome Kim. Dr. Kim, please do come forward. Let's give Dr. Kim a round of applause, and please do come forward, sir. Thank you. Dr. Kim is the Director General of the International Vaccine Institute. He is a physician and a scientist, obviously specializing in this area of vaccine development and global health. And his work is really the basis for what we need in the world today, equitable access to vaccines, especially in low and middle income countries. Dr. Kim, you have the floor.
Thank you, Dr. Smith. Dr. Mohammed Abu Fayez, Excellencies, colleagues, ladies and gentlemen, thank you. This is a wonderful opportunity to pay tribute to one of the global health leaders of the 20th and 21st centuries. And although, again, I'd never had the opportunity to meet Jong-wook, I feel like as he was the person who broke ground for the IVI building, that at the International Vaccine Institute, we all owe him a serious debt of gratitude. Just to explain what IVI is, it's a UN-chartered international organization dedicated to accelerating vaccine research and development for global health. Our mission, to discover, develop, and deliver safe, effective, and affordable vaccines, empowering vaccine equity, impact, and sustainability globally. I think this mission today is one of the most important things that we can say, the empowerment of vaccine equity, which not only means working to do technology transfers, but training people in countries around the world to develop vaccine security for regions and nations. You can see where around the world IVI works. We have now a headquarters in Seoul, regional offices in Stockholm and Kigali, country offices in Austria, and just recently signed a country office agreement in Nairobi, Kenya. You can also see the new laboratory that's opened up in Hong Kong. There are 61 now countries and WHO that have joined or are in the process of joining our international organization, and our first G7 member, Canada, joined on April 1st. So the theme of this discussion is global health leadership and Korea. And you don't necessarily always associate them, or Korea itself, with global health leadership, although it has had people who've had leadership positions like Lee Jae-wook, but also Ban Ki-moon and the Sustainable Development Goals. I mean, all of these things relate to a commitment in the country and a belief in development. Remember that Korea was colonized by Japan for 35 years and then suffered a major Cold War conflict where the capital of Korea changed hands 4 times. There are pictures of Seoul flat after the war. GDP per capita was $64 in 1955. By 2026, Korea had recovered. GDP per capita was over $37,000. And as you might expect, and you can see that in the panel to the left, Korea had started to give funding, official development assistance, starting around the late 1980s and early 1990s, and that amount has gradually increased, but the ODA to GNI ratio, ideally 0.7, is still 0.21. So Korea has a ways to go, but as with many countries that have just entered, that have gone from being dependent to being now independent and having funding available, you know, it takes a while for donors to understand, and this may be an opportunity for those countries, for the countries newly entering OECD, like Panama, like Korea 20 years ago. It takes some time to build up that history, that familiarity, that comfort with official development assistance and the work that it does for countries around the world in the same way that that same development assistance has helped Korea to develop. So Korea's progress from global health aid recipient to global health donor. Starting in the 1960s, Korea started to offer training programs to other developing country participants. So this is at a time when Korea's GDP per capita was lower than many African countries. When they were holding training in Korea, they routinely invited other countries from the region and elsewhere to participate in that training. Official development assistance started in the 80s. KOICA, Korea International Cooperation Agency, was established in 1991. The first financial contributions to UNAID started in 1996. IVI was founded in 1997. So we are the first international organization to be headquartered on Korean soil. A very important idea, but also one, if you speak to Professor Cho Won-kyu and the late Professor Sang-dae Park, they really said, we saw this as an opportunity. Korea needed biotechnology and innovation. We saw this not only as an opportunity for Korea to pay back, but to also as a way to develop the capabilities in biotechnology, which they saw as one of the next waves of future industrialization. So first contributions to the Global Fund in 2004. Then, of course, there was this period of time where Korea was using air ticket solidarity. It was less than $1 per ticket for people transiting through the new Seoul Incheon International Airport. And you'll see a little bit more about it because it really generated a significant amount of funding and allowed Korea to fully fund its contributions to other organizations. The first commitment to UNITAID, first contributions to Gavi, a new fund called the Wright Foundation, which funds innovation and the commercialization of innovation in global health technologies, vaccines, drugs, diagnostics, and digital health products for global health, with access agreements for all of these. First, financial contributions to the Coalition for Epidemic Preparedness Innovations, the founding contributions to the Pandemic Fund. So again, Korea is emerging as a donor, but as with many new donors, it needs to expand, it needs to, and now, actually, and you'll see the slides shortly, we'll need to start to think about our leadership role in this effort. So the Air Ticket Solidarity Program is interesting. Again, it was a $1 charge, kind of invisible to people, on every ticket for people using Seoul's International Airport. If you've ever been to the Incheon International Airport, it's really quite a remarkable place. It raised 425 billion won, which is about $300 to $320 million, and it was all for global health. It was really remarkable. 40% to multilaterals, 40% to multi-stakeholder projects and partnerships, such as those by the UNFPA and UNICEF, and 20% roughly to Korean NGOs and organizations like IVI for field projects in Africa. 100% of the Gavi funding came from this fund, and funding to Unitate also came from GDF. It supported, through the TB Alliance, the TBA, surfequilin, which is a new agent for drug-sensitive and resistant tuberculosis. It funded MMV's seasonal malaria chemoprevention study, and it supported cholera vaccination in support of generating data around the best use of cholera vaccine. So it did a lot, but unfortunately, it ended in 2024, and efforts are now in place to try and restore this fund because of the benefit that it had for global health. The next thing I'd like to speak to is what we call the Right Foundation, Research Investment Global Health Technologies. It's something that IVI, the Korean government, the Gates Foundation worked very hard to put into place. And if you have a question about how to do this, Youngmi Cho is sitting in the audience, and she was really the person at IVI who worked so hard to try and get this fund in place. But you can see that it's very much like the Global Health Technology Innovation Fund in Japan, 50% contribution from the government, 25% from Gates, and 25% from Korean companies. And since its inception in 2018, those three organizations have put in $102.1 million. On top of that, other organizations to develop these products have leveraged that with an additional $360 million. And when we think about what we need to do in global health, it's not only being more smart, it's not only about reducing our overall costs, but it's about innovative financing, thinking about ways to get other funders into the mix. And this is what the GHIT does. A 3.5 to 1 return on investment for the GHIT fund has allowed now, in the short period of time, 4 products to either be approved by regulatory authorities in Korea and now submitted to WHO for pre-qualification, an FDA-approved device, and a WHO pre-qualified diagnostic device. So these are real contributions to global health. And also then for the Korean government, it's the commercialization of innovation. It's building an ecosystem in biotechnology that the government can use that will generate jobs and innovation and IP in Korea itself. All of the grants are given with global access embedded in them, so that these are not things that are going to make billions of dollars for some company in North America. These are things that have to be, by definition, transferable and used in global health for the purposes it was intended. Official development assistance, and actually it was funny because I think he's not here today, but a former global health ambassador, I think you probably know him, said, ODA as we know it is dead. And for many organizations that depend on official development assistance, this would have tragic consequences. And so one of the things that IVI has been doing is really not only talking about what official development assistance does and the good that it does, and the people here don't need to be told what good ODA does. It helps to power schools, so it educates people, it provides vaccination assistance, it supports health services delivery, and other things. It helps to build water, sanitation, and hygiene facilities. ODA is important. One of the things that IVI has done is to look at what are the other things it does. And what are the benefits for the countries that give ODA? Because, you know, now some of the politicians are asking us, so what have you done for us? I mean, yes, we're giving money, we're helping to contribute to cholera vaccine distribution, development, generation of data, but what has it done for us? And we can say, well, look at this, the Wright Foundation. The Wright Foundation's generating products that Korean companies are making. That means Koreans are being employed. It's generating IP for Korean companies. Again, a good idea. It's the companies, QuadMed, LG Chemicals, U-Biologics, SK Bioscience, are companies that are working with the Wright Foundation to generate new products for global health. These innovations are going in to support other activities, so a secondary benefit, and leveraging good health for Korea. So there is a benefit to ODA, and it's not only to the countries where development assistance is used directly, but if ODA is used correctly, it can actually have secondary benefits for the countries that give it. And that is now, unfortunately, increasingly a common thing that we're hearing. So what is this doing for us? And we can articulate that. We hadn't thought of it that way, but as global health leaders, you're going to need to be able to look at the benefit of ODA in the countries that give it. So this is, again, IVI exists because of the government of Korea. They donated the land, which is next to Seoul National University. They built the building that IVI exists in, and this is the thing that Lee Jae-wook was involved in the groundbreaking for that building. But the things that IVI has done, the impact that we have had, is attributable to ODA, to a vision that a country that was a developing country, that became a developed country, should also make a contribution to others, to help others. So this could be the 180 vaccine development projects for vaccines for which there is market failure. You know, everyone thinks, the market works wonderfully. It works wonderfully in countries that have a big market. It doesn't work so well for a person who has schistosomiasis, because schistosomiasis doesn't exist in North America or in Europe. But the development of a vaccine for schistosomiasis is at the top of the list sometimes when we speak to ministers of health in Africa. Vaccine products that were pre-qualified, doses of the world's only oral cholera vaccine, lives saved from that oral cholera vaccine, vaccine tech transfers, the $450 million mobilized through the Wright Foundation. All of these things are impacts that we have. And as an international organization, we need to be able to articulate this to our funders. We have to do the work that we are designed to do, which is really around global health and improving health outcomes in low and middle income countries for vaccine-preventable diseases. That is our mandate. But we also have a benefit to the countries that fund us, and we just have to make that clear. So again, cholera is one of those wonderful examples. The oral cholera vaccine was made possible by support from Korea, Sweden, and India. It's really an important thing. The IVI oral cholera vaccine, now technology transferred to multiple different organizations, may be the basis for the first new vaccine manufactured in Africa in 100 years. If BioVac's vaccine is shown to be non-inferior to the existing U-Biologics vaccine, it will be the first successful manufacturing of drug substance in Africa in 100 years. This is the meaning of development assistance. It's not only teaching people how to farm, it can be teaching people how to manufacture a vaccine, how to package it, how to test it, and then how to use it for benefit and impact in Africa. So the great unraveling in global health, I don't have to tell you this, but 150 million lives saved over 50 years by EPI programs is not enough, and are under threat. But we have the middle powers. And what are the middle powers? Because depending on the person's example, they change. Those middle powers, Korea is the #4 supplier of vaccines to Gavi. India and China supply 70% of the vaccines to Gavi. These are middle powers. If you look at the cuts that many countries are putting into place, you have this group of middle powers. And what can the middle powers do? They can innovate. So GHIT, the Wright Foundation. Why not have a global Wright Foundation, which is something that we talked about at a side event yesterday? Global Disease Eradication Fund, which is air ticket solidarity. Middle powers can cooperate. Multilateralism is more important for middle powers, which means that we know how to collaborate. Facilitate transition from a global north-dominated system to a global system. Demonstrate and facilitate functional regionalism. So not regionalism that limits passage of people and technology, but regionalism that really helps the countries in the region and other regions as well. Middle powers can advocate, and the former Prime Minister of Singapore said, even small countries have agency, meaning that you have a mouth, you have an ability to say things officially, you should say things and advocate for the things that are important for global health, because the G2 are not going to occupy that center cross. It's the middle powers who need to step in and take control. Capacitate. We know that Korea has worked to try to improve training and build capabilities throughout the world. The Global Training Hub in Biomanufacturing, which is a WHO Academy sponsored training, the basic course in vaccine manufacturing, is supported by the Ministry of Health and Welfare of Korea. So when students come, the entire cost of the course is carried by the Ministry of Health and Welfare of Korea. So all the 1,000 people who've come through the 2 different courses in training have been funded by the Korean government. Educational partnership is critical. Technology transfer, IVI's done 14 technology transfers of 6 different vaccines. Others have done the same. You don't have to be Merck or Pfizer, because they are innovation powerhouses, in order to do technology transfer for the diseases that matter for the world. And finally, and this is the hardest point, because I can say middle powers should lead, but how do you get a government to step forward? And Mark Carney said a lot of things in his Davos speech, but he did say, when middle powers work together, we can do even more than protect ourselves and our sovereignty. We can build something better, more prosperous, and more just than what came before. And Canada just joined IVI, and I think we should challenge each other now to encourage those countries that are the middle powers to really begin to do the right thing, because 150 million lives were saved by advances in vaccines and vaccination since the EPI program was established. We cannot let that fall. We have to come up with the reasons. We have to be persuasive. We have to be cogent. We have to be able to understand what the donors want. But we need to get that money, because although IVI talks about being impact-driven, we have to have the funding sometimes to do that impact. And so we all need to be better at trying to find innovative ways to work together, innovative mechanisms to fund, and better ways to get the middle powers to step up and lead. Thank you.
That was brilliant. I think that's a perfect introduction to this next section, when we're going to be hearing from our panelists as well, having a panel discussion on this issue. Thank you so much for that, Dr. Kim. I'd love for us to be able to go back to your slide at some point, your last slide, and talk about that innovation and capacitation and coordination and advocacy, because I think those are some of the key areas that we're going to be needing to work on in the years to come. But let me first introduce the other members of our panel today. After Dr. Kim, I'd like to introduce Dr. Jong-wook, who is a former commissioner of the Korean Disease Control and Prevention Agency, and a real public health expert with much experience, particularly in the area of infectious disease research and policy, but also in international health governance. And Dr. Ji is also a member of the Independent Oversight Advisory Committee for the WHO Emergency Programme, a very key role. I've then got to introduce Ginny, which is really difficult. Ginny and I have worked together in one way or another since 1997, 30 years, at different times and in different roles. It says here that the notes I was given say Ginny is a global health specialist with experience in health system strengthening. I think that's an interesting way of putting it. I would have perhaps phrased it a little differently. Ginny has probably done more different jobs in WHO than any other person in the world, I should think. Working in the TB program, working on the Global TB Drug Facility, leading that, then getting taken up by Dr. Lee to his office and to support him as his executive officer and travelling all around the world with him. And then more recently doing a huge amount of work on non-communicable diseases, particularly TB control, tobacco prevention, and other NCDs. A giant in that area, she's done some amazing work. And then Iris is our new Ginny, I think, in some respects, a physician and a climate health expert specialising in sustainable healthcare and climate adaptation. And she's got a PhD, I believe, from the London School. Congratulations. Her work bridges science and policy and youth leadership, and I'm going to emphasise that bit, youth leadership, because that's really what we need in the world today. Is really a real new order, in a way, of our youth who bring such new ideas and creativity and willingness to work together. Need that in the world today. And in fact, I'm actually going to start the first question to you, Iris, because I also think that's what Dr. Lee would have done. If he'd had this forum stage, he'd have gone straight to you and he'd have asked you for your thoughts. You know, you've been working very closely with the Youth Council, with many young people who are interested in global health, who are committed to it. And you've been involved in the calls for stronger accountability and inclusion in global decision-making. What do you think it will take, then, to turn some of the important commitments that we've got in global health? No lack of commitments. What will it take to turn those commitments into real action, the action that is equitable and inclusive and really makes the changes that we're looking for? Over to you.
Thank you so much, Ian. Hi, everyone. It's such a pleasure to be here, and thank you for the invitation, and pleasure to be also with these esteemed fellow panelists. I think it's a really important question. I have the privilege to be one of the founding members of the WHO Youth Council, and I was a youth representative before that and after that, so I've seen a huge shift, I think, in the past few years even, in how youth is engaged in these types of spaces. But I also know from my colleague, Doreen van der Wal, that Dr. Lee, I think, was a big supporter of young people. So it's very, very much a pleasure to be here and speak on this. When young people call for stronger accountability and inclusion, they're not asking for symbolism, but they're really asking to fill the gap between what we're saying and how we actually act. It's also about connections across generations, building in sustainability, bridging the gap between all the knowledge that's been built up and the young people that are coming into the workspace, as well as, of course, bringing in creative new ideas, because we've grown up in a world vastly different from the generations before us. If I give 3 concrete shifts that I think we need to see in global health to make this more inclusive and equitable, I would start with decision rights, not just consultation seats. We see a lot of consultation, but that's not true inclusion. So across the multilateral system, we see that young people are routinely invited to speak, to advise, also to be photographed, but rarely invited to vote, allocate, to veto. WHO Youth Council, I think, is one of the better examples where that's the first institutionalized mechanism of youth engagement at the WHO at the global level, which I think was a huge step forward. The issue is also starting to change more. We actually saw at this WHA that the Czech Republic, the Netherlands, North Macedonia, and Slovenia raised a point, actually raised by the youth delegate of Slovenia, calling for a quota in young people in the WHO workforce. So I think that's exactly the kind of pressure that we need more of. The broader shift is also structural, so standing youth seats, decision-making authority, so not just observers, but actual members of what's going on. Second shift, opening doors and also paying for the work that young people are doing. So we need to have a fund, pipelines that produce young people into these spaces. To take one concrete example, the WHO Youth Delegate Program. So in 2018, we saw that 5 member states brought a youth delegate to the World Health Assembly, meaning a youth representative and really a youth voice. This year, 24. So I see a big increase, and I'm really excited about that. But that still means that we have around 170 member states that still can make that step. So if anyone is here in the room that can contribute to that, please do. And the asks here are concrete. I think this also goes into internship programs. This goes with stipends that WHO luckily has introduced now. Donors should refuse to fund unpaid placements. Visa support should be core part of the budget, right? So these are decisions that I think can be made quickly. And finally, I would say accountability. So we need to measure. And if we measure and we look at the HR report of WHO, we see that between the age of 20 and 29 in the workforce, it's only 0.66%. So that's very low. If we measure this, and we measure this across, so also in delegations, what is the engagement? How do we see people under 35 engaging in these types of spaces? We know where we need to improve. So let's do that and let's report on it. Dr. Lee called for health for all. He didn't call for consultation for all. He called for power, access, outcomes for all. So 20 years on, I think we need to question ourselves. Are we willing to make structural financial measurement decisions that turn that vision into something a young person in 2046 will actually want to inherit? Thanks very much.
Brilliant. So the first thing you need to do is to say, everybody who's here, contact your government and ask them what are they doing to make sure that their delegation to the World Health Assembly includes young people. Yeah? Great. That's one thing that everybody can at least think about doing. And I think you're absolutely right. Dr. Lee's first comment would have been, get on with it. Just do it. Yeah. Ginny, what you've got so much experience in this area, and you know both as, we've all been young people, haven't we, at one time or another, but what will it take, not just from that perspective, what will it take to really encourage a much stronger way of working together to ensure that we can actually see that progress that we need? Words, plenty of them, but it's the action that's always missing. What's it going to take?
And that's a really great question. I mean, just before I answer the question, just a comment to our esteemed speaker. JW would have loved your presentation. He was an incredible fan of his home country and very, very proud. And to you, JW was someone who gave a lot of confidence to young people. When I was 25, he put me in charge of a $30 million drug procurement program. He didn't just give lip service to young people, he gave them real work and real responsibility. And I think that's so important. In terms of implementation, how do we make it happen? How do we bring coalitions? I think our esteemed speaker at the beginning gave us some really good clues. It's really about making sure different sectors are working together, particularly the private sector, the public sector, civil society, NGOs, governments, and increasingly cities. JW, as I always called him, Dr. Lee, my esteemed boss for 2 years, was really focused on practical action. He was a humble leader, but he really insisted always on results. I never forget once, he came to me and a group of young staff and said, what are you doing? And we said, we're writing the 5-year strategic plan. And he looked at us and he just said, tear it up. Go and get on with the work. The work will lead to the results. The results will lead to the strategic plan. Get on with it. He was really big on clear vision combined with political urgency and really strong partners around the table. And, you know, one of the things I really learned from him when we worked with him in tuberculosis was the importance of having a very narrow technical package, a rather simple technical package, because he always said that public health is so complicated. You need to focus on simple areas or simple packages that are evidence-based, that can be scaled by governments, by partners. Get that right, and then everybody will coalesce around it. And I think his other examples are 3x5. You know, that simple slogan which catalyzed a generation of HIV activists to get people on ARV access. And when I moved into tobacco, I really took the lesson from Dr. Lee around building simple evidence-based packages, having coalitions of partners to support, and really focusing for the governments on the return on investment arguments, because they're interested, of course, in the health impact, but as our first speaker pointed out, they're also interested in the economic impact or the financial return. So in tobacco, we borrowed from Dr. Lee and his work in tuberculosis and said, okay, look at all the things we can do on tobacco. What are the most cost effective? What are the easiest for governments to implement? And we developed something called the Empower package, which is our tobacco equivalent of the tuberculosis package, and since then in non-communicable diseases, which of course are killing the majority of people in the world now. We have focused in WHO a lot of our work on these technical packages. But of course, having the technical package and having the partners is not enough. You've also got to focus on the data and monitoring the results. And that's really important when trying to focus forwards, because it brings a level of accountability. And JWE was very, very interested in accountability. And I'm really delighted to say that since we copied JWE's package for TB, we launched it in 2007. We protected 1 billion people in 2007, and this year we've protected over 6.5 billion people in the world with this narrow package, which is yielding results. So that was something I really learned from JWE.
Brilliant,
Thanks.
many thanks. So you've both mentioned issues around implementation and accountability. And those two key points, I think, are some of the areas in which we need to look to make sure that, how do we monitor to make sure things are happening in those two areas? Well, Dr. Xie, you have the opportunity now to tell us a little bit from your experience and what your perspectives are on leadership in terms of moving from words to action and accountability. And you're very much involved in that, I know.
Thank you. Firstly, I want to really emphasize a country's strong political will and sustained multilateralism are equally important. Although the gap between the commitment and implementation is ultimately about the resources, accountability and ownership at the country level, multilateralism remains indispensable. No single country can address complex health threats alone. Effective implementation depends on coordinated action across member states, international organizations, civil society, and private sector sharing resources, evidence, and accountability frameworks. At the same time, multilateralism must be action-oriented, translating shared commitment into concrete programs, measurable national results. Secondly, I will start with the WHO's role. WHO's Health Emergency Program, established in 2016, now marking its 10th year, has laid an important foundation for global health security. However, WHO regional offices and country offices, the most critical interface between global commitment and national action, continue to have insufficient resources in my mind relative to the scale of threat they face, and this must change. Regional offices and country offices need to be substantially strengthened so that they can provide sustained technical assistance and accompany countries through multi-year implementation process and serve as partners in building national resilience. Based on my own experience in WIPRO for 8 years, a stronger WHO presence at regional and country level is not optional. At the same time, WHO cannot work alone. In today's increasingly fragile global health environment, collaboration with broad network of health partners remains critical. In this context, the outcome of WHO joint external evaluation can serve as an invaluable starting point. providing country-owned, evidence-based assessment that identify gaps, align multi-partner support, and link political commitment into actionable targets that country offices and regional offices can help translate into sustained national progress. Third point is that evidence-based decision-making, robust data systems, and early warning mechanisms should be top priorities for all countries, and declaration of faith on ongoing Ebola outbreaks in DRC and Uganda, and hantavirus outbreak in cruise ship are clear examples. Strengthening IHR, particularly the legal obligations around timely reporting, must be first priority. And equally important is investing in real-time genomic surveillance capacity in LMICs, where many zoonotic spillover events can occur. I had an opportunity to participate in a side event organized by WHO Berlin Hub for Pandemic and Epidemic Intelligence earlier this week, and the hub established in 2021 represents a landmark investment in global early warning capacity. And countries should actively engage with these hubs platforms such as IPSN and EIOS, which together provide the powerful tools for real-time threat detection and data sharing. And my third point is still political will and country-level ownership must be at the core of any effective public health system. Technical mechanisms only function when national authorities truly commit. A domestically financed national action plan aligned with budget cycles and supported by parliamentary oversight and informed by civil society engagement can transform political commitment into actionable result. And finally, WHO collaborating centers and existing WHO networks must be fully and strategically utilized. As Dr. Jerome Kim presented, Korea has translated its global health commitment into actions by establishing International Vaccine Institute in 1997, Wright Foundation in 2018, and WHO Global Health for Biomanufacturing in 2023. And Korea's example, as Jerome mentioned, that demonstrate how middle power countries can serve as bridges to resource-limited countries and accelerate capacity building. I believe Dr. J.W. Lee would have been proud to see how far Korea has come as a global health contributor over the past 2 decades, and Korea will continue to build on this foundation in the pursuit of the vision in which he dedicated his life. And let us all work together for health for all. Thank you.
Yeah, thank you. That's a brilliant assessment. Thank you. I think you're absolutely right. I think he would be delighted in many respects with what he's seen, particularly in Korea, but in the world as well, in some of the areas where there's been real progress. But it's not been everywhere, has it? I mean, we had the Sustainable Development Goals, and those have, we're not going to achieve them, I think it's fair to say. And in fact, you don't even hear maybe in tobacco, good news there, but in general, no. And in fact, people have often, you don't hear many people even talking about them now. We've almost seemed to have given up. How can we restore hope? Because I think a lot about leadership is giving hope. How can we restore hope? Now, you gave the example of the Prime Minister of Canada, and I think his message was one of almost of trying to restore hope. Could you give a bit more on that? Because I think that's really important for us in thinking forward, not just in looking back.
So it's often said that hope is not a plan. Yeah. So this hope, or speaking inspirationally, is the first step. And I think that needs to be followed up by something concrete. And this is where Canada, some of the other G7 countries, and other middle power countries should get together and really start to organize, this is what we're going to do. And different countries have different interests. And this is one of the things I learned at IVI. I thought, it's all official development assistance, but certain countries have particular interests, like antimicrobial resistance. Other countries are very, very interested in climate change. The problem is, as with One Health, too often we fragment it into human health, animal health, AMR and climate change, and we don't think across these, the cross-cutting, the things that are cross-cutting, or I think the French people, I call them transversals, but the things that link these things together, I often have difficulty with One Health, actually, because I'm thinking of it from a vaccine perspective. And how do you wrap something together into one big plan that you can speak to a donor or a donor country or a group of donor countries about how vaccines integrate into this much broader One Health concept? And so I think I'd like to talk to you about this afterwards, because we really need to be able to articulate. We're in the middle of our 5-year strategy generation, and Dr. G was actually on our board, so she knows what this process is like. But we're in the implementation phase, and that means that we're going to need to come up with what exactly we're going to do. And it's as Dr. Lee said, yes, you're just going to go ahead and you're going to do things, and the strategy kind of presents itself. So a lot of the things that are now elements of the strategy were things that we started working on 2 years ago, and started generating data, and started putting together teams. And so I think that this is what the leadership is. It's, yes, Mark Carney inspired. Now, Canada and others should start to work together and say, this is what we're going to do, and this is how we're going to do it, and this is what we'll commit to it. And they may not want to commit a lot, but having, and I think everyone who works in global health knows, we never have enough money. Now we have even less, which is even more unfortunate. But are there other ways to do this? Are there people who are willing to step up and say, I'm ashamed of my government. They ought to be contributing more, and my foundation will do this. The Gates Foundation, if you look at the global health funding, it's dropped 15 to 20% across the board. But if you look at the Gates Foundation, if you look at the Wellcome Trust, their commitments have remained. Are there others who might be willing to do that, and are we going to pass a hat for global health? But we're only going to do that if we have a plan. If we can tell them, this is what we're going to do with it. We need to strengthen health delivery systems in low and middle income countries. We have to work on zero-dose children. So I tend to look at everything from a vaccine perspective, so I apologize for that. But, or we need to work on One Health. Why? Because when you look at that map that was just generated, it appeared in Nature about 7 or 8 months ago, where are these diseases going to emerge? And it was odd, because I thought it was going to, Southeast Asia. And Papua New Guinea was a hot spot, and so was Latin America. And again, that's not what we normally think, but it just emphasizes that this is a global problem, and whoever's trying to organize this has got to stop thinking about, well, the only problems are going to arise here, unfortunately in DRC, in the Democratic Republic of Congo, sorry. But we really need to start thinking more broadly about what is needed. We formed organizations almost 10 years ago that were supposed to make sure that there were vaccines. And they've made tremendous progress. I mean, during COVID, they forward-funded organizations. 4 of the approved vaccines came out of this funding. Can we do something like that for Ebola? Can we do something like that around Middle East respiratory syndrome, around Nipah, where there are ongoing outbreaks, and we don't yet have vaccines? And so how are we going to think about doing it and being accountable for the funding that we've received to do it?
Brilliant. Many thanks. I think we're having to come to an end. We've run out of time, but let me just quietly and summarize. Well, let me actually do it in a different way. Let's see, if we've been having this meeting in a year's time, and we were here after the new DG had been elected, and that DG was here, what would be the 4 messages that we would want to give to the new DG based on what we've heard today? If I may briefly summarize, I think it would be, we need vision. And that vision needs to be with a clear plan. We need hope and inspiration. We need implementation, and we need accountability. And I hope that that's the message that the new DG, when they come on board in a year's time, is communicating to the world about the future of WHO and the future of global health. But thank you all very, very much for this excellent panel.
So thank you, Chair and the panels. Can you stay here for a moment while we are getting a lift? Maybe we are too heavy. Here we go. So thank you, Chair, Dr. Smith, and the panelists for that rich and forward-looking dialogue. Now, we are moving to our final, and very special session, which centers on the voices and leadership of the next generation. Session 3, Shaping the Future, Strategic Directions for Sustainable Global Health Leadership and the Role of Youth. This session focuses on the role of youth and intergenerational collaborations in driving the future of global health. So we are delighted to welcome two co-chairs. Do you have them here? Yeah. Okay, guiding this dynamic discussion, Ms. Doreen van der Waal, a youth engagement and partnerships professional at the World Health Organizations, and Forever Youth from the Heart. And Dr. Iris Bloom, she sat on the panel for the last session, a physician and climate health expert specializing in sustainable healthcare and climate adaptation. Please welcome our co-chairs to the stage with a warm round of applause.
Good afternoon. Hi again, everyone. Welcome to the closing substance session of the Dr. Lee Memorial Forum. You already know me, but this session we want to make it super engaging. So I hope you're ready and have some energy to contribute, because we also want to hear from you.
Thank you, Iris. It's very nice to be here together with her. We work together at WHO, and we've been working together on youth engagement. And my name is Doreen van der Waal. I have worked with Dr. Lee since 1994, when I was 29 years old. And I am actually, she's the young part of the chairing, and I am the older part of the chairing. And this is also the purpose a little bit of the session, is bringing generations together.
20 years ago, Dr. Lee called for Health for All, a vision built on equity, courage, collective responsibility. Today's emerging leaders inherit that call at a moment of overlapping crises, a climate conflict, inequity, eroded trust. 20 years from now, in 2046, they will be the ones answering for it.
So before we introduce our speakers, we're going to do this slightly different, as this was actually designed by the young people, this session. It's going to be a little bit unconventional. So Iris is going to actually start by reading a letter, and to imagine that you would be 20 years from now, in 2046, and we're sitting in this room right now. Over to you.
Dear colleagues of 2026, it's strange to write to you knowing how much has changed and how much hasn't. When you gathered in Geneva 20 years ago, you didn't yet know which crises would compound and which would surprise you. You didn't know that the climate emergencies of the late 2020s would force us to redefine what an emergency even means. You didn't know that health for all would have to be argued for again and again in rooms where the air conditioning worked better than the trust. But here is what I want you to know. The decisions you make this year about who gets a seat, who gets a contract, who gets named in the next plan, those decisions are visible from here. Not all of them aged well. Some of them are why we are still doing repair work in 2046. So please be braver than you have to be. Trust earlier than feels comfortable. And when you find a young person doing serious work, don't make them ask for the microphone 3 times before you hand it over. We needed you, we still need you. With love and impatience, a colleague writing from 2046. So that letter, of course, is an imagined one, but the 4 people we are about to hear from are not imagined. They are members of the WHO Youth Council, and they are already are doing the work that the letter is asking for.
So let me start by introducing the 4 panel members to come forward. Katja Cic, please. So Yim, who is a young professional officer working in our team at WHO, Dr. Pablo Estrella Porter, welcome, and then Dr. Simeng Lee. Dr. Lee, coming forward. Over to you.
Great. A quick word on how the next 40 minutes or so will run. So this is not a panel. We structured it as 4 moves. So move 1 happened with the letter. Move 2, we will hear from our speakers on a sharp prompt in a very short time. Under 3 minutes, no slides, no full CVs, just their conviction. And in move 3, which is where you come in, we'll flip the room. You'll turn to your neighbor from a different generation, and we'll take some reactions from you. And then move 4, we'll close with a 1-line commitment of what you will do differently after today. So start thinking about that as you listen to them. And then we'll hand back to Kofi.
Katja, the floor is yours.
Thank you so much. So a very difficult prompt also demands a loaded response. So let me start with a bit of a hot take. We need to move beyond the heroic and often even savior language that we often use in this field when it comes to courage. I imagine many of you throughout this week have heard the sentence, "Youth are the future." Well, quite a few of us are alive today and a part of policies and systems that affect us. And the sentiment, "youth are the future," is actually double trouble. Because first of all, it's shifting the burden of solutions onto a new generation, which is a huge weight for us to shoulder. But it also avoids the accountability from generations that are currently holding positions of power. So back to courage. Courage for young people is not just speaking at conferences or advocating online. Courage is continuing to believe they belong in global health, even if the system often tells them otherwise. Because right now, entering this field is actually more difficult rather than easier. Young professionals are navigating shrinking WHO and donor financing, frozen internships, lack of short-term consultancies, which were for decades the entryway for young people into global health work. There's little stability, and the networking spaces often reward proximity, if you live in Geneva, New York, Copenhagen, and so on, privilege, or even existing connections more than talent or commitment. And often, today's global health institutions are asking young professionals to be passionate as a substitute for paying them fairly. And yet, despite that, young people are showing up. Courage, to me, looks like a student from a low-income background applying for opportunities they were never socially connected to access. It looks like someone from a tiny country, like mine, fighting off the imposter syndrome to feel like they belong or deserve a voice. It looks like an early career professional staying in public health despite financial insecurity and activist burnout. It looks like young people insisting that their lived experience is expertise, not just something to be consulted symbolically on after decisions are already made. But I also think we need to be honest, and we cannot keep celebrating resilience while normalizing exclusion. A field that is dedicated to equity cannot rely on unpaid labor or elite gatekeeping as the price of entry. If global health only becomes accessible to those who can afford this instability, then we risk losing exactly the perspectives that we urgently need. So courage today is also institutional courage. It's the courage for organizations like WHO, like Kofi, and other partners to rethink who gets opportunities, who gets paid, who gets visibility, and it means who gets to shape agendas. It means investing in pathways that are transparent, inclusive, and financially viable for young people from all backgrounds. And importantly, young people are not asking for charity. They're asking for intergenerational fairness, mentorship, and the ability to contribute sustainably to a field they deeply care about. Basically, they're asking to be treated exactly like all of you. And I believe the future credibility of global health depends on this. Because if we want systems that are equitable, representative, and trusted, then the pathway into those systems needs to reflect those same values. So when I think about courage, I think about young people who continue choosing service, solidarity, and public health, even in uncertain conditions. And I think about whether institutions are willing to meet that courage with structural change. And while I personally never had the chance to meet Dr. Lee Jong-wook, from stories told today and yesterday, I believe he had that courage. Hopefully, so do all of you.
Thank you, Katja. I think that is very well put. And it also gives a bit of an, how can I say, responsibility to the generation, the older generation from Katja, that we can actually make that difference for them. And we have to, yes, passion is important. And we always say, it's so great, young people here, we need youth engagement. But we need to actually, action needs to follow to recognize it and to also to give them that recognition that they deserve. And it makes me think back of what Ginny said when she was 25 years old and she was given a pretty heavy mandate with a big budget to handle. Indeed, this is exactly what Dr. Lee did with young people. I have experienced it, and many years later now I have learned that yes, it is sometimes it's hard. You have to force your path. You have to learn to navigate the different institutions, but we shouldn't make it more difficult for the young generation. We should really empower them and make it easy for them to be part of, to be with us as equal partners. Over to the next panelist. So-Yim.
Thank you very much, Doreen and Iris, and also a huge thank you to the Kofi Foundation for the opportunity to be part of this conversation. This topic really hit close to home for me as someone who's working at the WHO as a junior professional officer, also of course known as JPO, a program that really reflects a commitment by government, in my case by the government of the Republic of Korea, to really invest in young professionals and really entrust us with the responsibility to engage and contribute meaningfully within the UN agencies. And over the years, I did witness really a growing effort and interest across a lot of global health institutions to engage youth and value youth voices, which was very encouraging. But at the same time, I have this recurring thought in the back of my mind as to, but what's next? And what does it actually take for us to be trusted, not as a contributor, but also as a future leader? And at WHO, I work specifically on parliamentary engagement. And I would say one of the most important part of my work is to make sure that the commitments that are being made at the global level, like the ones that were being made throughout the week at the Assembly, that these commitments get translated and implemented into actual concrete action, whether it be through legislations, policies, or budgets. And one meaningful experience for me personally was to launch the World Health Assembly Global Parliamentary Forum, which was inaugurated last year and is now established as an annual and dedicated platform for parliamentarians to engage directly within the World Health Assembly, which really didn't exist before. And that was personally very rewarding moment for me to, as a junior professional, contribute to what I believed was a milestone within global health governance, and really being able to strengthen the political accountability and parliamentary engagement in global health decision-making processes. And I believe the same principles really could be applied when it comes to youth engagement, is by really turning into that commitment into concrete actions and outcomes, because that's where you can see the real impact. And the supporting young professionals really shouldn't be limited to one-off initiatives or short-term opportunities. If you're actually serious about ensuring to build a sustainable global health leadership, which is the theme of this overarching session, then we really need to make sure that sustained and international investment should be contributed for young professionals, so that they can be able to contribute substantively and also develop their expertise and grow into their leadership role over time. And just before closing, when I was reflecting on Dr. Lee's legacy, what really stood out to me was not only his leadership with humility, but also his undeterred courage to keep evolving, not only for himself, but also for the organization. So I hope that we could honor his legacy by following that footstep and doing the same for the younger generations. Thank you.
Maybe something just to highlight to what you say. I think very often we think as older people, older generation working at WHO, empowering and mentoring young people is actually not part of your job description. This is actually part of everyone's life job description. And this is something that we should naturally start doing. It's not something you want to be paid for or recognized for. It is actually working with young people. And I have the privilege to work with the Youth Council and with young people. And it's not something that you think it's an additional thing. It is so empowering and it's so enriching and it gives me so much gratitude to see these young people standing up and with passion and sometimes not remunerated, sometimes being here for very long hours, doing things after their work. And I really would like to encourage everyone here that we have those that have the possibility to really mentor young people, help them navigate the difficult working spaces that we actually are working in. WHO is not an easy workspace, but it's our kind of life responsibility to help these young people navigate these spaces, and it's really a privilege to do so.
Thanks, and with that, over to Pablo.
Thank you first for giving us this space, and especially because it was also a possibility for co-creating this session. As a junior doctor myself, youth is not waiting to become part of the health systems. In many countries and settings, students and early career professionals are already helping hold those systems together, often while facing low wages, unsafe and inadequate working conditions, burnout, fragmenting training, and even limited protection. The question is whether institutions will give us real leadership pathways before 2046, or only responsibility without real decision-making. By 2046, many of today's students and early career professionals will be leading hospitals, clinics, universities, ministries, and many other senior positions. I'm sure in 20 years, when our generations reach these positions, we will continue advocating for youth engagement and intergenerational leadership. But by then, probably it's already too late. The foundations of that leadership is being built right now. Too often, young people are asked to volunteer. Early career professionals are asked to cover gaps of the system, are expected to adapt to overstretched systems, often without enough protection, mentorship, or voice. This is not only a workforce issue, it is a leadership issue, and it's also an ethical issue. We see the consequences of inequity at the bedside of patients, in communities, and in training environments. We will see what happens when health workers migrate, because we've seen it ourselves, that they cannot build safe or defined careers at home. We see burnout normalized as commitment. We see digital tools introduced without enough attention to trust, ethics, or access. And we see prevention discussed as a priority, but often underfunded compared with crisis response. The real question is whether institutions are ready to trust us, the youth. Preparing students and early career health professionals to be ethical, trusted leaders means more than inviting us to youth panels. It means including youth in decisions about us. It means creating protected spaces where we can speak honestly without fear of punishment. It means teaching leadership not as hierarchy, but as a responsibility. Responsibility to patients, responsibility to communities, to colleagues, and to the population. It also means that ethical leadership starts early. If we train people in a system where exhaustion is normal, where silence is rewarded, and where young professionals are treated as replaceable resources, we should not be surprised when trust in health system declines. But if we train them in systems that value dignity, accountability, collaboration, and courage, then we're not only filling today's workforce gaps, we're building tomorrow's health leadership. So my last message, also to honor Dr. Lee's memorial, is do not call youth, students or early career health professionals, the future, while excluding them from the decisions that shape the future. So the action actually happens today, and it's happening at the moment. Thank you so much.
Thank you so much, Pablo. I think a very clear call to action. The health workforce is at the core of, actually, I think, everything that we do here. And I think you very clearly outlined the barriers that young people are facing. So thank you for doing that. And also young professionals specifically are facing in these spaces. And the mindset issue is one that I think is at the beginning of this. If we shift the mindset, and we've seen that shift with many people in WHO, slowly but surely coming because of these efforts that the young people are doing in these spaces, because they don't give up, they keep having the conversations, even if they're shut down. Slowly but surely, step by step, the mindset shifts. And once one mindset shifts, others follow, right? So we all have a responsibility towards that. And from what I hear, Dr. Lee did have that correct mindset, so that's great. I'm happy now to pass on to our final speaker on this move too, and that is Simeng, who will actually speak to us about the following sentence. The current model of youth engagement ensures broad inclusion of young voices across regions and social groups.
Thank you, Iris, for giving me the floor. I think just to also put that out there, I was asked to give a provocative statement on this. I currently do not think that the model of youth engagement that we have in 2026 ensures broad inclusion of youth voices across different spaces. Yes, we have visibility of youth in many spaces, this being one of them, for which we are very grateful. But there is a long way to go to actually go to meaningful inclusion of those youth. And young people are present, but oftentimes it also still they are the same youth every single time. It is people from who have the capacity to build networks, to engage, that have relevant backgrounds, that speak the language, that know the people that come to these spaces. I also recognize that I am one of them. I'm a medical doctor from the Netherlands. I am engaged in the Youth Council, have been able to engage in that space for the past 8 years. Have had the privilege to study in a high-income country, learned multiple languages at an early age, which also gives me the opportunity to engage here. And I'm very happy to the organizers of this panel, and also to the WHO Youth Council for providing that space. But also, I think it's important to underline that there's many other young people and students here around the world that do not have these capacities or opportunities given to them, but that does not mean that their opinions are no less valuable than mine. And in that sense, also when we talk about broad inclusion across groups, regions, sectors, youth inclusion is often seen as something that we have to do, but we don't actually know how to. When youth are very diverse, we are different people, we are individuals, we're not just one homogeneous group. Recently I read in a very renowned medical journal about how to do youth engagement, how to do engagement in a panel. And it really challenged our view on how we set up panels like these in big global health conferences, where we often see that we just have to tick a box. So we bring people in from different backgrounds from academia, and at some point someone says, oh, these are all people from the global north that work in academia, what can we do? Let's bring in a young person, a woman, someone from the global south. And oftentimes it is the same one person that ticks all those boxes. And I really do not think that that is the way that we should go forward on this, because youth inclusion is broader than just someone being brought on stage to tick the box. And then moving on to the local level, I want to highlight the barriers that young people face. The people that can engage in decision-making spaces, panels, conversations are once again young people that have connections, resources, education, speak the right languages. It's not the students or young professionals that are working, taking care of family members that do not have for example, for refugees do not have the right to stay in a certain country, are not in school, for example. Where are those young people? Do we actually have their voice heard when they might need it most, more than the people that can actually make their way into those spaces? And in that sense, this is also a call for both having youth engagement at a global level, but also ensuring that we have youth engagement on a local level, where closest to the people, closest to the community, closest to the needs of people. That's where you can actually find young people that represent what we need, and also the people that they work with, rather than in global spaces like these. So I think my question or challenge to everyone today is, what do we want to do? What does youth engagement mean to us? Is it actually something that we just want to look upon and tick a box, or do we actually want youth engagement that affects people in local communities? If that's the last thing is what we want, which I hope that we can agree on, I think we need to move on from only including highly educated young people that have rich connections, that have an academic background, to be the voice of youth, so to say. And we need to start investing in actually creating these mechanisms in local areas where change can be made faster, rather than in global institutions, global arenas, where we might not hear people that needs to be heard most. Thank you.
I think you raised a really good point. I think, yes, we are very often, especially whether we are at WHO, the UN, or spaces like this, very often most of us come from very privileged backgrounds. And so when we talk about inclusion, it's true, we do pretty well on gender. I think we do at least at WHO, I think we do a good job on geographical representation. Youth is really getting there, and the youth is really going for it. But indeed, is what you say, what about low socioeconomic status? There is a huge potential in countries, in universities, where people or young people would never get the chance to be invited to spaces like this. And yet they could have brilliant ideas. And they have actually very important lived experiences that some of us might not have had. And they're not necessarily at the table with their stories, with their challenges and their life challenges that they face every day. So making sure that we include young people from low socioeconomic status as well. And I believe fellowship programs, like Coffee has an important fellowship program in Dr. Lee's name. Fellowship programs would be an incredible way to bring fellows from not only high-income countries, but making sure we bring fellows in from low and middle-income countries, but from local universities. So thank you very much for the statement. I think it was a very powerful one. Thank you.
Thanks very much. If I can add one challenge to that, is that I would ask us all to consider the role of privilege that privilege has played in who we're listening to, but also the role that privilege has played in why we are in this room. Thanks very much. We will now move to number 3 of this session, and we're going to need you to do something. So I'm going to count down, and after I've counted down, what I would like you to do is find someone in the room from a different generation. I'm also going to invite the panel to participate and find someone. And I will ask each of the pair to speak for 90 seconds on this prompt. What is one thing your generation is getting right that mine should learn from? So you'll have 90 seconds. After that, I'll say time's up, and then you switch, and the other person will speak for 90 seconds, and that's it. And towards the very end, we might hear from some of you. So 3, 2, 1, let's go. Time is up. So please let the other person speak for 90 seconds. We have 20 seconds left. All right. Hello? Yeah. All right, time's up. If I could have everybody's attention, kindly. And if you could kindly take your seats. Because our time is up. And I would like to ask the panelists to come back with us on the stage. If the panelists would want to come back here and everybody else takes a seat. And, okay. Now, I would like to hear 3 voices from the room. So, is there anyone here? I'm walking around in the middle in case you don't see me. Sorry, I'm continuing. Is there anyone who would like to raise something they've learned from the conversation? Anyone? Yeah. Yeah, learned from the person you were talking to. Very quick.
Very quickly, the youth were saying, youth is a nice label, isn't it, is saying that, that they need to also be humble in not thinking that they know more than they actually do. That was just one specific spit.
Great. Anyone else? Yeah, Beth?
So we were talking about the fact that we think kind of young people are very kind of open with their kind of ideas, and the fact that if something isn't kind of the way we agree it, we're happy to kind of say that. And then we also discussed about the importance of also that intergenerational relationship and also having kind of respect and listening to generations that have kind of been there before us and kind of learning together, and also the importance of mentorship and how that works both ways between a mentor and a mentee.
Discuss the importance of middle ground, meeting each other. Thank you. This is a great panel.
Nice. I see one more hand over here, so I'm running across the room.
Hi, I also learned that so with the older generation, she mentioned that in the past they had very limited resources, and so when parents had opportunity, the first thing they would do is to invest in education for their children. And so my generation should also learn that, I mean, luxury is good, but investment is key. Yeah.
Thanks so much. Is there anyone else on the other side of the room? Okay, I see 2 more hands, so 1, 2, 3, very quick, each of you.
I learned that the older generation was looking backwards most of the times, and this generation is looking forward, and that would make a change.
Very nice. Okay, running this way. Where were my 2 people? Yeah, over there. Great.
So it was Millennial and Gen Z, and my notion was, I think millennials started this push in the workplace, particularly in the West, for more diversity. And I think Gen Z have taken it further. So this was our exchange here.
Thanks. Was it yes? Final intervention from the floor.
It's same to the point that the older generation or the previous generation does invest in our education, and on the other hand, from the youth as well. If you look around the room, we're still here, and we always stay, and we always show up. I think that's one area that we should appreciate.
Thank you so much. I nicely got back to the stage. Is there anyone on the panel that would like to share a quick thought? Anything?
So we discussed that the younger generation is perhaps better at setting boundaries for work-life balance, but the older generation was a part of the system building, so they know all the entryways, all the shortcuts, or the pathways, so they're better at navigating the current systems.
Perfect. Thanks so much. We're going to move to move number 4, our final move of this session. If the older generation cannot figure it out, please move to your partner that you just spoke to for help, and they can help you. We are going to ask you to submit one thing you will do differently after today. So you can scan this QR code, and then you can fill out your one sentence of the one thing you will do differently after today. Perfect. So take a moment to scan and think. If you cannot figure it out, go back to your other generation. They can help. We're going to start to see some results. Dream bigger, think loud, sleep more. Nice. Spend more time with family. Be proactive. Say something, not only thinking. Voicing out my views. Nice, those align. Giving more validation to ideas of my children. I like that one. Do. Venture outside the beaten path and continue to push for diversity. If the mission is global, retire. Nice. Create alliances and work together across differences. That's very nice. Great. I think we will leave this on so you can still submit or also take a look at what's coming in. I will now pass over to my colleague for some final words to close off this session, but I would also like to highlight that I think with Doreen, I am experiencing one of the best intergenerational partnerships. As you've heard from her, she is an incredible supporter of youth engagement, and she spoke to how to walk the talk and for this to be central to work. And if there's one embodiment of what she's actually been telling you, it would be her. So it's such a pleasure to be co-facilitating this session with her today and also to work with her every day. So thank you so much, Doreen. I'm looking forward to hearing from you on the final reflection.
Well, I guess there's something that stuck with me from working with Dr. Lee for a long time, because he was indeed that person that there was no young, middle age, or older people. He empowered everyone. And today, social connection is actually a big word, and we're losing social connection. Social connection is a big issue today. And the purpose of the session today was a little bit to socially connect with each other and to make that effort. And I actually want to give 2 anecdotes that actually, when I think of Dr. Lee, is 2 things that he did, and I think it gives a really good picture of who he was. He was a very visionary man. He was always empowering people, no matter what age. And he always wanted to drive change, but doing it in a concrete, no-nonsense way. That's sometimes a challenge at the UN, because there's a lot of blockages and there is a lot of bureaucracy. And I think that is what I learned from him. And also that he allowed people to make mistakes. And I very, very remember when I was very young, he entrusted me with a project, and I made a mistake, and I had no idea how to justify myself, I felt so bad. So I went to Dr. Lee's office and I said, I'm so sorry. I started to justify why this happened. And he told me, Doreen, I don't want to hear your justification. You know what you did wrong. And you will do better next time. And it's fine to make mistakes. It's fine to make mistakes. And I trust next time you'll do the right thing. And then there's another thing Dr. Lee always did. At the end of the day, he would always take rounds across the building. And he would walk in at random in people's offices. He would sit down and he would talk to people. And he would ask people, how are you feeling? What are the issues? Because as a Director General, you're often isolated. People protect you from what's really happening down, where you don't necessarily get to hear what is happening. And he was always interested to know what was happening at any level of the organization, with anyone. And this is something that has stayed with me as such a powerful thing. It's like he always wanted to hear firsthand, how are people doing and what are people feeling? Not just the work, not just what WHO had to perform. It is how is the work, how are the people feeling in the organization that are actually the success of the organization. So I just want to leave words of thanks to Dr. Lee of being an extremely humble, inspiring, and a man that is led by a great, he was a great example. So thank you very much for all of you being here today and listening to my great colleagues, and I hope some of the messages you really take away into your daily life and into your work. Thank you very much. Over to you.
Thank you, Doreen, Bloom, and all the speakers of the most, how can I say that, stimulating session. And I also learned a lot, and then I will do something different from tomorrow, for sure. And also, thanks to Doreen for mentioning about our fellowship program. I'm the director of our capacity building program, and then I'm very touched that she mentioned and she knows about our program. And as we conclude today's program, we extend our sincere appreciation to our all speakers, panelists, and also participants for staying these long hours. You know, I have never seen this many people retaining even after 4 or 5 hours, so it's very thankful. And on behalf of the Korea Foundation for International Healthcare, thank you all for joining us today, and we wish you a very pleasant evening. And we prepared the cocktail dinner outside that might come as a surprise, but so please enjoy and have an opportunity to interact with each other. Okay, thank you very much.